Alright, a very good afternoon to all of you. So we start again with obstetrics, what we were doing yesterday. We had done the management of postpartum hemorrhage and a little bit more, so a little bit more is left from PPH before we actually go on to change the topic. Now yesterday, if you remember, I said there is something that we do is controlled cord traction, right? And then I said, if we don't do this controlled cord traction, yes, hello Tanda, hello Shimla, so universal hello to everyone. We're just continuing now. So I said, if we don't do a controlled cord traction, then what will happen? The uterus is going to invert. So I had introduced this term yesterday to you people. And the term was uterine inversion. Yes, this was the term I introduced, but we did not talk anything about it. Now what happens is in uterine inversion is the fundus first dips down and eventually the fundus comes out via the cervix. The fundus of the uterus comes out along with, and if it is more, then the cervix and the vaginal walls would also come out. So this is the vaginal walls and this is the fundus. So this is what is inversion, right? This is what is inversion uterus. The fundus is going to get inverted and then come out of the internal os, the external os, the vagina, and so on. Now what happens is immediately after inversion of the uterus, the patient goes into shock. So as soon as the uterus is going to get inverted, the patient goes into shock. Now the reason for this shock is neurogenic shock. So this shock is neurogenic in nature, called as neurogenic shock. Now what do we mean by this shock? Now what happens is, yesterday we did so many ligaments that were attached to the uterus and the cervix, right? Now similarly, the ligaments attached here were the Mackenrod or the transverse cervical ligaments. Now when there is inversion of the uterus, there is stretching of these ligaments. Okay, there is stretching of these ligaments, and the stretching of these ligaments in turn produces a vagal response which causes neurogenic shock. So the first shock to develop in inversion uterus is neurogenic. But eventually what happens is, once this uterus inverts and comes outside, it also becomes atonic. So the neurogenic shock initially will eventually convert into a hemorrhagic shock. So the initial shock in inversion uterus is neurogenic, but later it converts into a hemorrhagic shock, and if this shock is very severe, it can even lead to death. Right? Just it was doing in postpartum hemorrhage. So this is what is happening in inversion. Now what is the treatment of inversion? Treatment is simple. Since the uterus is swollen outside, what are we going to do? We are trying to reposit the uterus back, right? We are going to reposit the uterus back. And when we talk about reposition of uterus, then the first method we try is manual reposition. The first method we try is manual reposition. This is the first page, don't worry. I said I had introduced the term inversion uterus yesterday, but I did not explain what is inversion uterus. So inversion uterus is one of the causes of postpartum hemorrhage, we said. So when we talk about inversion uterus, we said that the fundus inverts, comes out via the internal os, external os, and eventually the vagina. So this is how inverted uterus would look like. So this is the fundus and these are the vaginal walls, right? Now, then we said that immediately after inversion occurs, the patient goes into shock, and the type of shock is called as neurogenic shock, right? The reason for these neurogenic shock or this neurogenic shock is stretching of the uterine ligaments. So we said there are a lot of ligaments attached to the uterus. So these ligaments undergo stretching. They produce a vagal response, which in turn leads to neurogenic shock, right? But then we said that neurogenic shock then converts into hemorrhagic shock. Why? Because the uterus which has fallen outside becomes atonic, and eventually there is postpartum hemorrhage. So the first shock to develop in inversion is neurogenic, but it actually converts later into hemorrhagic shock. And this hemorrhagic shock, just like it was in postpartum hemorrhage, may be severe enough to cause death of the patient. Now, then we are doing what is the treatment of inversion uterus. Since the uterus has fallen outside, what are we going to do? We are going to put it back. And the first way we try putting it back is called as manual reposition. Okay, it is called as manual reposition. Manual reposition means we are going to try putting back the uterus by our hands. So, the concept we use in manual reposition is the part which comes out last is to be reposited first. So this is the rule we follow. The part which comes out last is to be reposited first. So if we look at this picture again, the first thing to fall out is fundus, whereas the last thing to fall out is the vaginal walls. So what we do is we start replacing the vaginal walls, and as we keep replacing the vaginal wall, the fundus will automatically keep going inside, right? Now, ideally the uterus should be relaxed. So the uterus should not be tonically contracted, because if it is contracted, the ligaments will also be taut and we'll not be able to put it back. So in order to put it back inside the vagina or the pelvis, the uterus has to be relaxed. So we do this in a relaxed uterus. We try and reposit it by manual reposition. If manual reposition fails, then the next method we use is called as hydrostatic method. Next method is called as the hydrostatic method. Now the hydrostatic method, as the name suggests, if this is the uterus which has fallen out, again we do the same thing, connect an IV fluid bottle via a tubing, and with the pressure of water, this uterus is tried to, is put back into the pelvis. So this is called as the hydrostatic method. It has a name. It is called as O'Sullivan's method. It is called as O'Sullivan's method. If the hydrostatic method also fails, then the next step is to take the patient to operating room, and what we do is a laparotomy. Now what happens is, when you first take the patient to the operating room, again the first thing we do after anesthesia, after you give anesthesia to the patient, and what is the preference of anesthesia here? It is going to be a general anesthesia. Now why general anesthesia? Because in general anesthesia, once you give it, there is maximum relaxation of all the organs. So the uterus and the ligaments which were taut will completely relax. And therefore, after you give the anesthesia, you should try manual reposition again. Why? Because sometimes the cause of failure of manual reposition was taut ligaments. Once these ligaments relax, maybe you are able to put it back just by a manual method. So we should try manual reposition again. Okay. But if this fails, then yes, you will have to do a laparotomy. Laparotomy means opening of the abdomen, and then we have to pull up the uterus from the pelvis. We are not left with any other option. This is uterine inversion. Now, why is again important is, there are a couple of MCQs which come from this part. And how are they framed? So let's see if you can answer them. Then I'll give you the answers, right? So the first question is, a patient goes into shock after normal vaginal delivery. What is the most probable diagnosis? So anybody can give me the answer. I'm saying a lady goes into shock after normal vaginal delivery. What is the most probable diagnosis? Anybody? Anybody wants to write an answer? Inversion, no. Yes, so Kota is right. The answer is going to be postpartum hemorrhage. The most common cause of shock after delivery is PPH. Okay, the most common cause of shock after delivery is PPH. Now, what should be written in the MCQ such that we change the answer to inversion? What some of you are writing. The question would change as, a lady goes into shock immediately after or just after delivery. Now, what is your diagnosis? Now, in this case, the answer changes to inversion. Please understand, we have just added two words in front of PPH. One is immediately, or the other word that can be used is just. Now, why do we change the answer? Because postpartum hemorrhage will take some time for the shock to develop. It cannot occur just after delivery of the baby or immediately after delivery of the baby. There has to be some amount of blood loss which is significant enough to put the lady into shock. So it takes time. Therefore, if the question specifies these words like immediately after or just after, then the better answer is inversion, because in these cases it is neurogenic shock which comes up immediately as soon as the inversion is there. Do you understand the difference between the two questions? It becomes a very confusing question. Until you understand the concept, you will not know the answer. So now is it clear why in one case we have answered as PPH, while in the other we have answered as inversion? Yes or no? The third question, which is again important, is a lady dies after normal delivery or after delivery. What is the most probable cause of death? Yes, now what is the answer? A lady dies after delivery. What is the most probable or the most common cause of death? Yes, very good. The answer still is going to be postpartum hemorrhage. PPH is very common, and yes, it is the most common. As I told you, it is the most common cause of hemorrhagic shock in a postpartum woman, right? Now, if they ask you cause of death, in inversion uterus, the next question is, what is the cause of death in inversion uterus? Now, what is the answer? What is the cause of death in inversion uterus? Excellent, Haldwani. I think I'm really proud of you guys. Yeah? Yes, the answer is hemorrhage. Neurogenic shock never leads to death. It can be compensated, right? But eventually I told you that neurogenic shock gets converted into hemorrhage because that uterus is atonic and it bleeds quite a lot. So even if they ask you inversion and what is the cause of death, the answer is going to be hemorrhagic shock and not neurogenic shock. So these are very similar questions which appear, but we are just changing one line and it keeps changing our answers, right? The next thing which we talk in PPH and which becomes important for us as well is genital tract trauma. Now these are called as perineal tears. These are called as perineal tears. The perineal tear can be first degree, second degree, third and fourth degree. Right? So perineal tear can be first, second, third or fourth degree tears. A first degree tear is one which involves only the skin and or vaginal mucosa, right? So a first degree tear is which either involves only the skin and or the vaginal mucosa. A second degree tear is when the perineal muscles are torn. So when the muscles are also torn, it is a second degree tear. And what is a third degree tear? So one which involves the external anal sphincter is called as a third degree tear. And fourth degree tear is when even the rectal mucosa is torn. Right? So this is how we divide the perineal tears into first, second, third and fourth degree tears. Now, a first and second degree tear are repaired in the labor room itself. Right? So, the first and the second degree tears are repaired in the labor room. Whereas, when we talk about the third and fourth degree tear, then these are considered as emergencies. They are also called as complete perineal tear. So they are called as emergencies and they are called as complete perineal tears, right? Why emergency? Because if you don't repair them, because they have to be repaired in 24 hours. Why do they have to be repaired in 24 hours? Now what happens is, whenever the external anal sphincter is torn, for example it is torn here, then what will happen? The two ends of the external anal sphincter gradually will undergo avascular necrosis, right? They lose their blood supply and they undergo avascular necrosis. So we have to repair them within 24 hours so that they don't undergo avascular necrosis. If you have delayed it or you could not identify it in the first 24 hours, then it leads to avascular necrosis and you can never join two necrosed parts or you cannot suture two necrosed areas. So now you have to wait for neovascularization to occur, for fresh ends to appear, and then you will suture them back. So they could be done from a varying length of 6 weeks after delivery. So that means for these 6 weeks after delivery, the patient will remain what? Fecal incontinent, right? For 6 weeks, the patient is going to remain fecal incontinent, which is a very bad idea. So that is why we say that they are emergencies. They should be identified and repaired in the first 24 hours. Now, other thing about the third and the fourth degree tear is that they are repaired in the operating room or in the operating theater, and they are repaired under anesthesia. So we need anesthesia. And the anesthesia of choice is usually spinal or epidural anesthesia for this purpose. So they are repaired in OT, they are repaired under anesthesia, and the order is like this. The first structure to be repaired is rectal mucosa. The first structure to be repaired is rectal mucosa, followed by internal anal sphincter, followed by external anal sphincter, right? Then vaginal mucosa, then the muscles, and finally the skin. So this is the order in which we repair these structures: rectal mucosa, internal anal sphincter, external anal sphincter, vaginal mucosa, muscle and skin, right? Now this was about the tear. Now there is something called as episiotomy. Now episiotomy is described as a planned incision on the perineum. It is described as a planned incision on the perineum. Now there are two types of episiotomies: mediolateral and median. So the one that we give in the midline is called as or a straight in the midline is called as median. So if this is the perineum of the patient, this is the external anal sphincter. The mediolateral episiotomy is directed like this, whereas the median episiotomy would be directed like this, right? So this is median, this is mediolateral. Now the median episiotomy has many advantages over mediolateral. What are those advantages? There is less blood loss, there is less pain. So less blood loss, less pain, early recovery. So less blood loss, less pain, early recovery. Isn't there, what are you writing, Aurangabad? Right, I couldn't understand what you're writing. Isn't there patho right now? I think there is some confusion with the Aurangabad center. What is the confusion with the Aurangabad center? It was supposed to be an OBGY class, Aurangabad. Okay, so sticking back to what my alright, so the median episiotomy, so they were just taken aback, right? They were not prepared for OBGY. Anyways, so there is less blood loss, there is less pain, there is early recovery in a median episiotomy. Whereas all these are more, so more blood loss, more pain. It takes longer time to recover. But even then, I tell you that we prefer to give mediolateral episiotomy. Can anybody tell me why? I don't know. Aurangabad, I think there is some confusion because all other centers know that it was OBGY. Right? Anyways, yes, so I'm saying even though everything is more and mediolateral, still mediolateral episiotomy is more commonly given. Why? So the correct reason is, almost all of you are correct. The reason is because in case the median episiotomy extends, right? In case the median episiotomy extends, it will go and involve the external anal sphincter and it will tear the sphincter. Whereas there is no problem. Mediolateral episiotomy just extends into the muscle. So even if it gets extended, there is not going to be something very drastic that is going to happen, right? But we don't want the external anal sphincter to be torn, and that is why we say mediolateral is what we preferably give whenever it is to be given, right? Next which form of genital tract trauma is there? Next we talk about is a hematoma. So vaginal hematomas, or for that matter even perineum hematomas, are quite common after delivery, right? Now how does a hematoma present? So the hematoma presents in the form of pain at episiotomy site. So patient is going to complain of pain at episiotomy site. Secondly, the patient is going to complain about inability to pass urine. So there is inability to pass urine. There is extreme pain at the episiotomy site. On examination, the patient may have tachycardia. The patient may even be in shock depending on how big the hematoma is. And there is a bluish tender swelling. So on examination there is going to be tachycardia, the patient may even be in shock, and then there can be a bluish tender swelling at the site of or at the perineum. Most hematomas are managed conservatively. Most hematomas are managed conservatively, right? Now since most of them are managed conservatively, you must know what are the indications for surgical management. So what is the indication of surgical management of a hematoma, right? I think there is some confusion now. People, do you really want to attend OBGY or not? Stop typing that it was pathona. I am here, so we'll go ahead with OBGY, right? Now, if you talk about what are the indications for surgical management, then indications are: number one, anytime a hematoma which leads to hemodynamic instability in the patient. Anytime if it leads to hemodynamic instability in the patient, irrespective of the size of the hematoma. So if it is leading to shock, then definitely it needs surgical management. Second, a hematoma which is increasing in size. So hematoma which is increasing in size is again an indication for surgical management. And third indication for surgical management is a hematoma which causes extreme pain. Again needs surgical intervention. And what is the surgical intervention? The surgical intervention is incision and drainage of the hematoma. Right? Incision and drainage of the hematoma. What do we do in the conservative management? In the conservative management, on the other hand, we simply give ice packs to the patient. Right? Now, the ice packs do what? They vasoconstrict the bleeding vessel and reduce the blood vessel and also provide pain relief. So, ice packs is what we give to the patient usually in the conservative management. Along with ice packs, we do vital monitoring. So we want to see the vitals of the patient and we want to ensure that the vitals are not deteriorating, right? So this is about what we call as genital tract trauma, or the more common types of genital tract trauma. A rare type of genital tract trauma is uterine rupture. The most common cause of uterine rupture is previous cesarean section. So the most common cause of uterine rupture is a previous cesarean section. Then we say a non-scarred uterus, so which means uterus which does not have any scar on its body. Can it rupture? Can a uterus which does not have any scar on its body rupture? So the answer is yes. So even a non-scarred uterus can rupture. And this is seen in women who are multiparas. So as the parity increases, yes, the risk of rupture uterus, even if it is non-scarred, increases. Right? Okay. So with this, we finish postpartum hemorrhage is the topic. And we go on to the next topic, which although not related, yes, but is equally important, is called as antepartum hemorrhage. Right? It is called as antepartum hemorrhage. Now, how do we define antepartum hemorrhage? Antepartum hemorrhage is defined as any bleeding from or into the genital tract, any bleeding from or into the genital tract beyond 28 weeks of period of gestation is called as antepartum hemorrhage. So any bleeding from or into the genital tract beyond 28 weeks of POG is APH. The APH for us is mainly of two types. It can be either placenta previa or it can be abruption. So how do we define placenta previa? Yesterday we had done that in pregnancy there is formation of a lower uterine segment, right? Now a placenta previa is a placenta which is located in the lower uterine segment. And any time if a placenta is located in the lower uterine segment, it has higher tendency to bleed. So even if the os opens up a little, the placenta will begin to bleed, right? And therefore it presents as antepartum hemorrhage. What is abruption? Abruption is premature separation of a normally located placenta. So premature separation of a normally located placenta. So in this case, what is happening is that the placenta, although is located in the upper segment, it begins to separate, just like it was happening in the Schultz method. But in Schultz, it was occurring after the delivery of the baby. Here it is occurring before the delivery of the baby, right? So again the placenta separates from the underlying decidua, that is premature separation of a normally located placenta, right? Now what is the first we'll talk about what are the risk factors for the two types, placenta previa and abruption. So when we talk about risk factors, three risk factors are common to both. No. There is separation which begins in the, there is no reason why it will begin in the periphery. It has to begin from the center, and there is formation of a retroplacental clot. That is how we define abruption. That is how a placenta in abruption separates, right? Now it can be Duncan's as well, right? What you are asking, can it be Duncan's? It can, but classically this is how we describe. When I come to types of abruption, I will make it more clear to you. But here it is the classical form that we are describing to you. Okay? Now the risk factors karte hain, and then I will tell you the types gradually, and then you will understand how or what kind of a separation it is and what it can present as, right? Now, if you talk about the risk factors, 3 risk factors are common to both. Which ones are those? Increasing maternal age is a risk factor common to both abruption and placenta previa. Then, increasing parity is again common to both. Smoking is again a risk factor for both placenta previa and placental abruption, right? So these 3 factors are common to both abruption and placenta previa. Talking about still the risk factors, the most common risk factor, or rather we should write it as most important instead of most common. The most important risk factor, how smoking leads to problems with implantation. There is defective implantation of the placenta because smoking, you all know, produces a lot of mediators, right? And all those inflammatory mediators, they lead to improper implantation. So that is how it is a risk factor. Now, some things you would just have to learn up, right? For everything, we may not have a reason, but yes, smoking does lead to improper implantation, and as a result of which, it is a risk factor for both. Now, most important risk factor is previous history of placenta previa. Previous history of placenta previa. After one placenta previa, the recurrence rate is going to be 5%. The recurrence rate is 5%. Whereas if you talk about abruption, again the most important risk factor is previous history of abruption, just like for placenta previa. But here when you talk about the recurrence rate, it is much higher. The recurrence rate after one previous abruption is going to be 12%, right? Then again, if we talk about placenta previa, history of previous cesarean section increases the risk. History of previous cesarean section increases the risk. After one cesarean section, the risk of placenta previa increases to be 3-fold. There is a 3-fold increase in risk in the incidence of placenta previa after one cesarean. And the risk keeps increasing with the number of previous cesarean sections. It keeps increasing with the number of previous cesarean sections. The other risk factors for placenta previa are presence of a fibroid uterus, presence of infection in the uterus, for example endometritis, because they all lead to improper implantation. So presence of endometritis or presence of a fibroid uterus, they are again going to be risk factors for placenta previa. What about abruption? What are the other risk factors for abruption? Folic acid deficiency has been related to abruption. Both polyhydramnios and oligohydramnios are known to be risk factors. So poly is increased liker, oligo is decreased liker. Both can cause abruption. Premature separation of membranes is again a risk factor. Then there is a condition called as APLA. APLA stands for Antiphospholipid Antibody Syndrome. Right, so antiphospholipid antibody syndrome is again a risk factor for abruptio placentae. There is a condition also called as thrombophilia. Thrombophilia is when there is increased clotting factors and thereby increased tendency of the blood to form clots. So thrombophilia is again a risk factor for abruption. Very importantly, abruption is related to preeclampsia. So again, and this is a very strong association between preeclampsia and abruption. Preeclampsia is a high blood pressure in pregnancy, right? So again, it is related to abruptio placentae. The last risk factor for abruption is trauma. So trauma to the uterus is again a risk factor for placental abruption. So if any patient comes with a history of being hit on the abdomen, a pregnant lady, when she comes with history of being hit on the abdomen, you should always keep abruption at the back of your mind as a differential diagnosis. What you have to see in that patient will come gradually, but yes, you should keep abruption as your differential diagnosis, right? Next we come to how do these present, right? So placenta previa, or first let us do the types, otherwise you will keep getting confused. So if you talk about the types of placenta previa, they are divided into 4 types: type 1, type 2, type 3 and type 4. Type 1 is called as a low-lying placenta. So a placenta which lies in the lower uterine segment is called as type 1 or low-lying. Type 2 is called marginal. By marginal we mean that the placenta reaches up till the margin of internal os. So if this is the internal os, this is how the placenta is situated. Right, so this is what I am showing you. If this is the internal os, the placenta reaches the margin of the internal os. So this is type 2 or marginal. Type 3 is called as partial, where if this is the internal os, type 3 I am saying is partial. If this is the internal os, the placenta partially overlies the internal os. So placenta partially covers internal os, but it will move away once os dilates. So once the os dilates, the placenta is going to move away from the internal os. Type 4 is called as a complete placenta previa, also called as a central placenta previa. So type 4 is complete or central, where the placenta completely covers the internal os. So it is complete or central. So it completely covers and the placenta will not move away even when the os dilates. The placenta will not move away even when the os dilates. So type 1, type 2, type 3 and type 4. Now there is a further division of type 1 and type 2 into A and B. So type 1 and type 2 are further divided into A and B, where A means the placenta is located on the anterior wall of the uterus and B means it is located on the posterior wall. Similarly with type 2, A is anterior wall and the B is the posterior wall. Now there is a second classification other than this type 1, 2, 3 and 4, which says the placenta previa are divided into minor and major. They are divided into minor and major. Now, what do we mean by minor and major? So, type 1, both A and B, and type 2A are called as minor degrees, whereas type 2B, type 3 and type 4 are called as major degrees of placenta previa. Now the reason we divide them into major and minor is the mode of delivery, right? Now we say that the minor degrees of placenta previa, can be delivered by vaginal delivery. So for minor degrees of placenta previa, the mode of delivery is going to be vaginal, right? Whereas for major degree of placenta previa, but really you will have to see the slides later. I really can't repeat all of it again, right? I'm sorry, maybe later you can just see the slides. We're doing antepartum hemorrhage. We finished postpartum hemorrhage. We took up some things from PPH and then we have started with antepartum hemorrhage. Okay? Now, we said, repeat all of it again. Dhule, I said type 1, type 2 and type 3 and 4 were the different types. Then we said we further divide them into minor and major. The minor were type 1A and B and type 2A, whereas major were type 2B, 3 and 4. Now the mode of delivery in major degrees, the mode of delivery in the major degrees of placenta previa is always a cesarean section, whereas the mode of delivery in the minor degrees of placenta previa is, I said, vaginal. So here it is going to be a cesarean section for the major degrees. Coming to types of abruption. So, the first type of classification of abruption is called as revealed, concealed and mixed. Now what do we mean by revealed hemorrhage? Revealed is what some of you were asking me, that can it be the Duncan's type of separation? So if it is Duncan's type, what will happen? Whatever bleeding is coming is going to be come vaginally as well. So there is all of it is going to be bleeding per vaginum. When this happens, it is revealed. When it results in the formation of a retroplacental clot, it is called as concealed. So when there is bleeding, all the bleeding that is occurring is coming out, it is a revealed type of a hemorrhage. Whereas if the hemorrhage which has occurred results only in the formation of a retroplacental clot, it is a concealed type of hemorrhage. The third type is called as mixed. where both are occurring, revealed and concealed. And out of the three, mixed is the most common type of abruption. The mixed abruption is the most common type of abruption, where there is going to be some amount of external blood loss and some amount of blood loss is going to be contained inside the uterus in the form of blood clots. Okay? There is another classification of abruption, and it is called as Pade's classification. Now the Pade's classification means there is type 0. First is type 0. By type 0 we mean it is a retrospective diagnosis. Type 0 is a retrospective diagnosis, which means patient comes to the hospital, she delivers. After delivery we find that when the placenta comes out, there was a retroplacental clot that was lying there. So that is why we say it is a retrospective diagnosis. So that is type 0. In type 1, the patient presents antepartum. The patient presents antepartum with vaginal bleeding along with pain abdomen. So the patient presents with vaginal bleeding and pain in the abdomen. But the fetal heart rate in type 1 abruption is normal. The fetal heart rate in type 1 abruption is normal. So this is type 1. Then comes type 2. In type 2, how does the patient present? So in type 2 abruption, the patient now presents with bleeding per vaginum. She presents with pain, but along with this, there is going to be fetal heart rate decrease. So the fetal heart rate starts decreasing, right? So it shows, why does the fetal heart rate start decreasing? Why? Because whenever placenta separates from the decidua, that part sort of becomes non-functional. So the uteroplacental blood flow is going to reduce. If the uteroplacental blood flow will reduce, what will reduce? The oxygen supply to the baby will be reduced, right? And it manifests in the form of decrease in the fetal heart rate. Okay? Finally, there is type 3. In type 3, there is bleeding per vaginum, there is pain. The baby, in fact, now dies in utero. So the uteroplacental circulation is so reduced that the baby dies in utero. But the point which puts the patient in type 3 is going to be shock. So in type 3, the patient herself lands up in shock. So she has lost significant blood and she lands up in shock. Also, there may or may not be DIC. DIC is what? Disseminated intravascular coagulation. So in type 3, definitely the mother is in shock. She may or may not develop disseminated intravascular coagulation, right? So these are the types of placenta previa and abruption. Next, what we talk about is that you as doctors, if a patient comes to you in the casualty or in the OPD, wherever, with antepartum hemorrhage, what are the points which help you make a diagnosis whether you are dealing with placenta previa or whether you are dealing with abruption, right? Revealed and concealed. So revealed basically means that whatever blood loss is occurring from placental separation is going to be expelled outside. So it will be presenting only as bleeding per vaginum. Concealed means whatever blood loss is occurring is all hidden behind the placenta in the form of a retroplacental clot. Nothing or very little blood is going to be, discharged outside. And the third type, which I said is the most common type, is going to be mixed, where elements of both are present. Page type 0 is, it's a retrospective diagnosis. So patient doesn't come with any complaint. She comes to the hospital and she delivers the baby. But you make a diagnosis of abruption after delivery. And how do you make it? When you see the maternal side of the placenta, you find there is a presence of a retroplacental clot there. So when you see a clot lying behind the placenta, which means on the maternal side of the placenta, it means it is a retroplacental clot, right? So that is a retrospective diagnosis, which is type 0. So coming to the differences again between placenta previa. So we say placenta previa classically presents as painless vaginal bleeding, whereas no, concealed and type, they are two different types of classification. You cannot compare the two, right? Concealed is just when there is hemorrhage inside. There may be some amount of blood loss externally or not. In the literal sense, if you want to compare it, you can say that it is a type of 0, but you can't say it is equal to type 0. We don't, equate the two classifications. There are just two different classifications given by two different people. Yes, but literal sense, yes. There will just be a retroplacental clot, and we will pick it up only post delivery, right? When we examine the placenta. So placenta previa presents as a painless vaginal bleeding, whereas abruption is painful. Second point, placenta previa में the fundal height is either equal to the period of gestation. The fundal height is either equal to the period of gestation or it will be less than the period of gestation. Whereas in abruption, usually the fundal height is more than the period of gestation. Now why is the fundal height more than the period of gestation? Because inside the uterus now, along with the baby and the placenta, there are going to be blood clots. So blood clots are going to fill the uterus, and that is why the fundal height apparently appears larger than the period of gestation, right? So because of blood clots, the fundal height appears larger than the period of gestation. Then placenta previa की bleeding is described as fresh red in color. So it is fresh bleeding and it is red in color. Whereas the bleeding in abruption is described as altered color or dark color. Now why is it altered color? Because the blood is retained inside the uterus for some time before it is expelled outside. And as we all know that blood, any blood clot over time undergoes changes in the colors, right? So that is why it appears altered or dark colored in abruption, whereas it is fresh bright red in placenta previa. Placenta previa is described as causeless, by which we mean if you ask the patient कि आप क्या कर रहे थे जब आपको खून जाना शुरू हुआ, so most of the times the patient will say that she was not doing anything. In fact, she was resting when she started having vaginal bleeding. So this is called as causeless. Placenta previa ki bleeding is causeless, whereas abruption is usually associated with a preceding event. The preceding event may be preeclampsia, it may be trauma, but usually there is some preceding event for abruption, right? Now, Alright, I'll hold it closer. Now, further, what are the differences in the two? Now, further, if we talk about placenta previa, both placenta previa and abruption have higher risk of malpresentations. But if we compare the two, in which malpresentations are more common, then they are more common in placenta previa as compared to abruption. Malpresentations are more as compared to general population in both placenta previa and abruption. But if you compare these two, they are more in placenta previa as compared to abruption, right? Then the next thing is, what about congenital malformations? Congenital, I think I'll change the battery, maybe that helps you a little, right? If we talk about congenital malformations, just give me a moment, I'll change the battery. Since all of you are feeling that, let us change the battery and see. We were talking about congenital malformations, right? Now what I am saying is that the risk of congenital malformations is increased in both placenta previa and abruption. So it is another association that we have seen, that the risk of congenital malformations has or is increased in both placenta previa and in abruption, right? Okay. Next, what we talk about is, still doing the differences between the two, the next thing which we talk about is fetal heart rate abnormality. Fetal heart rate abnormalities are less common in placenta previa and they are more common in abruption. They are more common in abruption, less common in placenta previa. The next point of difference is, after fetal heart rate abnormality, there is a classical history in placenta previa called as warning hemorrhages. By which, what do we mean? That if you ask the patient that, did you ever suffer similar episodes of vaginal bleeding before? So what is the patient going to say? The patient says, yes, there had been smaller episodes of bleeding PV, but those blood loss was very less. This time the blood loss is much more, right? So that means the uterus is giving warnings that it might bleed any time very severely. So those are called as warning hemorrhages, which are a feature of placenta previa, whereas abruption is usually an acute event. Abruption is usually an acute event, whereas warning hemorrhages or similar histories are present in the past in a patient with placenta previa, right? Then if we still talk about abruption, if I ask you what is the most common presenting complaint, what is the answer? What is the most common presenting complaint in abruption? Is it pain or is it bleeding PV? Yes, what is the answer? Pain, says Mysore. Anybody else? What is the most common presenting complaint? Okay, So the most common presenting complaint is going to be bleeding per vaginum and not pain. Pain is only specific. Majority of patients, even with abruption, present with the history of bleeding per vaginum. So that is the most common presenting complaint. The second question is the blood loss in placenta previa and abruption maternal blood or fetal blood? Which blood is being lost in placenta previa and abruption? Is it maternal or is it fetal? Maternal, yes. So it has to be understood that in both the conditions, whether you talk about placenta previa or whether you talk about abruption, the blood loss that is occurring is maternal blood loss. So my next question is, or something which is asked in the exams and it's considered as a difficult question is, what percentage of blood loss leads to intrauterine death? What percentage of blood loss leads to intrauterine death of the baby? Anybody knows the answer? What percentage of blood loss leads to intrauterine death of the baby? And the answer is 50%. So we say, very good. So who's given us the answer? Aldwani has given the correct answer. Very good. So we say when 50% of blood volume is lost, right? So how do we say this? We say when 50% of blood volume is lost, it leads to IUD of the baby, right? Now just a couple of minutes back or a few minutes back, we had asked you, or I had said that in abruption, there is risk of disseminated intravascular coagulation. Now what is the cause of DIC in abruption? What is the cause? The cause is that when the placenta separates, from the decidua, it leads to release of tissue thromboplastin into maternal circulation, and it is this tissue thromboplastin which initiates the process of DIC, right? Which initiates the process of DIC. In fact, this question comes in another form. The question also comes as, what is the most common cause of DIC in obstetrics? What is the most common cause of DIC in obstetrics? So you get another MCQ like this, and the answer here is going to be what? Abruption. So abruptio placentae or abruption is the most common cause of DIC in obstetrics or in pregnancy. Right? Now, the problem with placenta previa and abruption is that once the process begins, right? Once the placenta begins to separate in abruption, it is a self-propagating event. Why? What will happen? मान लो सेंटर से शुरू हुआ तो पहले hematoma is going to be small, then it is going to extend further till it involves the entire placenta, right? So it is a self-propagating event which causes more and more of placenta to separate. So is true for, so abruption is self-propagating, right? And when you talk about placenta previa, the reason of the bleeding is that the placenta is lying very close to the internal os, and when the os is dilating, it is bleeding. Or even in this case, the basic thing is that the placenta separates because of its unusual location and starts to bleed. Now, if I ask you, what is the single best management of these two conditions? Can you tell me? What is the single best management of these two conditions? Whether I say placenta previa or whether I say abruption. Bed rest. No. What will happen with bed rest? What is going to happen? That with bed rest, the abruption is going to keep on expanding, right? What will you do if you keep the patient on bed rest? Yes, so Bhatinda is right. The only management of these two conditions is delivery. Why? Because the cause of bleeding in both these conditions is the placenta. The cause of bleeding in both these conditions is placenta, and until and unless you take out this placenta, it will keep bleeding, right? So now what we are going to write is, what are the indications for termination of pregnancy? What are the indications for termination of pregnancy? So the first indication is going to be hemodynamically unstable mother. So whenever the blood loss is such that it leads to shock in the mother, then what do? We don't have any option but to immediately deliver the patient. So whenever the mother goes into shock, the answer has to be immediate delivery, right? Second, fetal distress. If the blood loss is so much that it leads to fetal distress, then again it is an indication for termination, because if you don't terminate, then the fetus may even die in utero, right? Third indication, continuous bleeding PV. So what happens is that you initially keep a patient of placenta previa on bed rest, as you said you would do, and if she keeps bleeding, what do? There is only one management, as we said, that if a patient continues to bleed, there is only one management, and that is to take out the cause, and the cause is the placenta itself. So continuous bleeding PV is another indication. Then patient goes into active labor. So if the patient starts having uterine contractions that lead to dilatation of the cervix, then again she has to be delivered, because there is no other way of stopping this labor, because until unless you hasten the process, she will keep bleeding. Agartala, I don't think you have a patho class today. I don't know what is this confusion. Guys, there is some confusion with you guys. There is no patho class today, right? So I'm going to teach up till 8:30. So, are you really interested in studying OBGY, or what batch are you, Agartala? There's no patho class today. I'm sorry to inform you that. Yeah. When will I teach pathology? Now, that's going to be probably in my next birth. Maybe I'll teach pathology. For this life, I am stuck with OBGY. I'm sorry, but you'll have to bear me for OBGY now. So if patient goes into, okay, so if patient goes into active labor, then again the patient has to be delivered. Abhi dhyan idhar do, ab sare, okay. Then at 37 weeks, at 37 weeks, so whenever a patient of antepartum hemorrhage reaches 37 weeks, irrespective of whether she is bleeding or she is not bleeding, she has to be delivered. Why? Because beyond 37 weeks, labor is going to start any time. And whenever labor is going to start, the placenta is again going to bleed. So at 37 weeks, it is an absolute indication to deliver the patients of antepartum hemorrhage, right? Next, if there is fetal intrauterine death. So if the baby has died in utero, there is no point of continuing the pregnancy. You would have to deliver the baby. And the last indication is congenital malformations in the baby. Now again, this is something very, very conceptual and you have to understand. When I say congenital malformations, I mean those malformations which are severe and which are incompatible with life. Right? For example, we will not cause delivery for polydactyly, which Hrithik Roshan has. He has an extra finger. So you think we should deliver a baby just because a baby has an extra finger? That is also a congenital malformation. But we don't mean those congenital malformations. We mean only those congenital malformations which were severe enough and which are incompatible with life. Now this table that I have given you right now is a very important table. You'll be able to solve a lot many MCQs from this table itself. So this table becomes really, really important. Also, you should understand that the order of importance is the order in which I have given you the table. So for example, if I ask you that all these are written in the options and I ask you which of the following or all the following are indications of termination except, I'm repeating my question, I say all the following are indications for termination except, and the four options are going to be from this table. Then which one are you going to choose? Which one are you going to choose? Fourth. No, then we'll choose the last, right? Congenital malformations. Very good, Belgaon and Bareilly. Yes. So congenital malformations, mate, there is no emergency in delivering the baby, right? There is no emergency, yes. So that is why I said we are going to follow the order. And you do have questions like this which have come up in the past where all the four options are going to be in the table. So the seventh one is the least important, followed by sixth, and so on and so forth, right? So the last two are the least important indications for termination. Now, once we have the indications for termination of pregnancy, there is another table, or I won't give you the table, but simply if I say, let's see how many of you have understood it. So simply if I say, what are the indications for conservative management in a patient with placenta previa? What are the indications for conservative management in a patient with placenta previa? Can anybody tell me how to get the answer to this question? What are the indications for conservative management in placenta previa? So we are just talking about placenta previa right now. So no, the answer is going to be very simple. No, Haldwani. In fetal distress, we cannot do conservative management. How to get the answer is just keep putting no in front of all the conditions we have written, Abhi. So the mother should not be hemodynamically. Yes, very good. So opposite, just the opposite of whatever 7 points we have given. Just keep putting no in front of it, and you will get another table where you will know the indications for conservative management. So mother should not be hemodynamically unstable. There should be no fetal distress. There should be no continuous bleeding PV. The patient should be less than 37 weeks. The baby should be alive. There should be no congenital malformation. Do you get it? So simply you just have to keep putting no in front of it and you will get the indications for conservative management, right? Similarly, if I ask you that if a patient is hemodynamically unstable, so if a patient is hemodynamically unstable, what should be your next step? What should be the next step in a patient who is hemodynamically unstable? Now here we are asking you particularly the next step. The answer would be what? No Bhatenda. That's the absolute management. CS. Very good, Bareilly. So Bareilly has come up with the answer. The answer to the question with next step is going to be blood transfusion. So any time if a patient is, yes, or as Hubli has put it, A, B, C, D, right? So airway, breathing, circulation, that is the order we follow. So we always stick to an order, when that similar order whenever the patient is hemodynamically unstable. So if you are particularly asked what is the next step, the next step is blood transfusion. But what is the absolute management? The absolute management is delivery. Why? Because even if you keep transfusing her blood, she will keep losing all the blood vaginally. So there is no point just replacing the blood if you are not conducting the delivery. Right? Do you understand? So the two have to be done together. You have to arrange blood and start blood transfusion, at the same time arrange for delivery of the patient. Right? So this is the next way how the MCQs try to confuse you by just changing words. So they will write next step, the answer changes. They'll ask you what is the definitive management, the answer changes. Right? Now the conservative management of placenta previa. The conservative management of placenta previa is called as McAfee's protocol. So the conservative management of placenta previa, we have a special name and it is called as McAfee's protocol. What are the components of this McAfee's protocol, that is the conservative management? So in this, yes, we do give bed rest to the patient. We monitor the vitals of the mother. We monitor the blood loss. We do fetal monitoring, by which we mean that we are going to look or keep a close watch on the fetal heart sounds, that they are normal and there is no distress. If the patient is less than 34 weeks, then we do need to give what? Steroids. So then we do need to give steroids, and we give steroids for what? We give it for fetal lung maturity. Now again you need to know which steroid do we give and what is the dose in which we give. Anybody has any idea which steroid do you give for fetal lung maturity? Very good. Yes, so the answer is betamethasone. And Haldwani also knows the dose. So again, I'm proud of you. A lot of your seniors who are exam going don't know the dose. So the drug we give is betnisol, 12 milligrams. It is given intramuscular, 2 doses, 24 hours apart. So we give 12 milligrams of betnisol, or called as betamethasone. Betnisol or betamethasone. So 12 milligrams is given intramuscular, 2 doses, 24 hours apart. Okay. Now can you tell me, can blood transfusion be a component of conservative management? Can blood transfusion be a component of conservative management? So Bhatendar says no, Mysore says yes, Latour also says no. Now, my question to the people who are saying no is, do you give blood transfusion only to patients in shock? So whoever said no, Bhatenda, Latour, tell me, do we give blood transfusion only to a patient who is bleeding or who is in shock? Or do we give it sometime else also? Come up, Bhatenda and Latour and Bhatenda. Yes. See, you need to clear your sometimes else also. And when is that sometime else? The sometime else is if the patient is severely anemic. So if I have kept the patient in my ward, she is a case of placenta previa. I said I am going to do conservative management in which I send all her blood samples. What if she comes out to be 5 gram % hemoglobin? Will we give blood transfusion or not? So the answer is yes, we will give blood transfusion. So blood transfusion is only symptomatic management. It can be done in conservative management. It can be done in active management. We want to build up a patient of placenta previa because otherwise in the next episode, whenever she begins to bleed, what will happen? She will quickly go into shock and you might even lose the patient, right? So please understand, blood transfusion can be a component of both active and conservative management, right? Whereas cerclage. Now cerclage is what? Or completely called as cervical cerclage. Now what is cerclage? Oh God, Agartala, this is foundation batch, please. This is a foundation batch class which you are attending. It's not a TND. Agartala is highly confused. It's not a TND, people. It is a foundation batch class. Are you guys from TND? Yes, Agartala, are you guys from test and discussion batch? Just give me a moment, people. Agartala, are you coming up with the answer? I'm waiting, guys. All right. So please don't worry. Why are you getting so worried then, Agartala? You are pre-foundation, right? So this is the foundation batch class which is going on. Oh, okay. Right, so we stick to the class now, quickly. So cervical cerclage is a stitch on the cervix that we put. Right, it is a stitch on the cervix that we put so that the patient does not go into preterm labor. Now please understand, cervical cerclage is never done in placenta previa. Cervical cerclage is never done in placenta previa. Alright? So, why am I emphasizing on this? Because you get it as a question. So the question comes as, all are components of conservative management of placenta previa except, and the options are going to be A, blood transfusion, B, let's say betnisol, C, cervical cerclage, and D, tocolytics. So can you tell me, my question to you is, all are components of conservative management of placenta previa except? Yes, so the answer is going to be C, cervical cerclage. As I said, cervical cerclage is not put in patients with placenta previa, right? What about component D? I did not tell you anything about it right now. So, tocolytics are agents which inhibit uterine contractions. They inhibit uterine contractions, and they can be given to patients with placenta previa. In what condition do we give tocolytics in conservative management? So this is the following indication. Now tocolytics are given in conservative management in placenta previa. अरे भटंडा, अगर आप वहां पे प्लासेंटा बैठा है नीचे, if you put a stitch there, you will put it into the placenta previa and it will start bleeding, right? So you never do or try and put any stitch on the cervix when there is a placenta lying there. You don't want that placenta to start bleeding, right? That's the reason. So tocolytics are given in conservative management of placenta previa when the patient is less than 32 weeks. The patient is less than 32 weeks. The uterus is irritable or is having mild contractions. Or not 32, it should be 34, right? So patient is less than 34, the uterus is irritable, that means there are mild contractions of the uterus, and you want to give betnesol cover. So you want time, you don't want the patient to go into labor. So that is when we want to buy time in order to have the effect of betamethasone. What do? We give tocolytics which will inhibit these contractions and prevent the patient going into labor, right? So this is the indication for tocolytics given in placenta previa. Now when you talk about abruption, certain points in abruption are different from placenta previa. What are those points? Number one, there is no role of conservative management in abruption. Can you tell me why there is no role of conservative management in abruption? Why is there no role of conservative management in abruption? Anybody? Right, so how do we exactly put it? Not fetal death and not shock, but exactly I said that abruption is self-propagating. Right, so it has started from one point and it will go on involving the entire placenta, and yes, eventually it will either lead to IUD or it will lead to what? It will lead to DIC, right? So it will either lead to IUD or it will lead to DIC. The second point is, since there is no role of conservative management, then there is no role of tocolytics in abruption. Since you don't want to stop the process of labor, you want the process of labor to rather set in. So we do not give tocolytics in abruption. Right? Then the third difference is only management of abruption. The only management of abruption is evacuation of uterus or delivery, as we say. The only management of abruption is evacuation of uterus or delivery. The next point is, how do we know what is the risk of DIC? So if there are two patients of abruption with me, how can I predict which one of these two will enter into abruption and which will DIC and which will not go into DIC? So the time since onset of abruption, the time since the onset of abruption tells us the risk of DIC. The more is the time, that is, the more you delay delivery, more is the risk of disseminated intravascular coagulation. And the earlier you conduct delivery for these patients, less will be the risk of disseminated intravascular coagulation. Right? Now, can you tell me what is the investigation of choice for abruption and placenta previa? What is the investigation of choice for abruption and placenta previa? Yes, very good. So the investigation of choice is ultrasound. What do we see in placenta previa in ultrasound? So what we try and see is distance of placenta from the internal os. What we see is distance of placenta from the internal os. And what do we want to see in abruption? We want to see presence of a retroplacental clot. Presence of a retroplacental clot is what we want to look at in abruption, and the distance from internal os is what we want to look at in placenta previa. Right? Now, I just said ultrasound, but for placenta previa, transvaginal ultrasound is better than transabdominal. Now, ऐसा लगता है कि transvaginal ultrasound will cause more bleeding, right? Because you introduce it into the vagina. But no, a transvaginal ultrasound is safe and it is more sensitive for posteriorly located placenta previa. For posteriorly located, so transvaginal ultrasound is safe and it is more sensitive for a posteriorly located placenta previa. So TVS is better than a transabdominal scan, right? Another thing which you have to understand in placenta previa is, or in any patient of APH. Now the rule that we follow is, in any patient who presents with antepartum hemorrhage, in any patient who presents with antepartum hemorrhage, a PS and a PV examination is contraindicated. A PS and PV examination is contraindicated till we rule out placenta previa on ultrasound. So until and unless we rule out the presence of placenta previa on ultrasound, we should not do a per speculum or a per vaginum examination in a patient with antepartum hemorrhage, because it will result in excessive bleeding PV if you do such an examination in a patient with major degrees of placenta previa, right? Now, the next table I'm going to give you is, yes, I said it is absolutely contraindicated till you do an ultrasound. If the ultrasound says there is no placenta previa, then you can surely do a PV as well as a PS examination. But if we don't have an ultrasound, then the first thing to be done is an ultrasound to look for presence or absence of placenta previa. Okay? Yes. Initially, what people do is they start with a transabdominal scan, and then, as I said, a posteriorly located placenta previa can be very easily missed on a transabdominal scan. So the better scan to be done is transvaginal, which is safe. Now, a difference between PV examination is that you're going to introduce your fingers into the cervix close to the internal os, whereas the transvaginal scan ka probe is not put inside the cervix. We just keep it in the vagina, right? So it doesn't cause bleeding PV as would you do your PV examination. Okay? Now, another thing that I said I'm going to give you is the next table, which is What are the indications for cesarean section? Indications of cesarean section in APH. So the first indication is a hemodynamically unstable patient. A hemodynamically unstable patient. That means if your patient is in shock, you don't have much time, and the only way to quickly deliver the patient is going to be a cesarean section. Second indication is fetal distress. Right? So whenever the fetal heart rate is dipping, we have to urgently deliver the baby, because if we don't do so, the baby will die in utero. And the only method to quickly deliver out the baby is by doing a cesarean section. The third indication is major degrees of placenta previa. So we just did, very good, yes Belgaon, type 2B, type 3 and type 4. So any time if there is a major degree of placenta previa, then again what we are going to do is a cesarean section. Now these indications that I have written are specific to APH. Just to complete the list, any other contraindication to vaginal delivery, right? For example, you are writing malpresentation. So anything which is otherwise a contraindication for vaginal delivery, it itself becomes a contraindication here. But these specific ones are hemodynamically unstable patient, fetal distress, major degrees of placenta previa, right? Now, with respect to placenta previa, there is something else that you should know. What is that something else? It is called as double setup examination. So it is called as a double setup. अरे बेटा, अगर एक पेशेंट शॉक में है बरेली और उसका शॉक का कारण वो प्लासेंटा है, then you can't wait for 10 hours की वेजाइनल डिलीवरी होगी फिर प्लासेंटा, एंड एनीवेज प्लासेंटा मेजर डिग्री में तो निकलेगा ही नहीं ना, मेजर डिग्री में तो एनीवे आपको सिजेरियन करना है ना. सो hemodynamic instability means the patient's condition is so severe that if you don't deliver the baby quickly, she will keep, she'll go into shock and probably die. And the only method to do it so is a cesarean section. Otherwise, are you going to wait for 8 and 10 hours and so on and so forth for vaginal delivery to occur for a shock patient? We can't do that, right? Now, what are you trying to ask me, Mysore? What if placenta is present anteriorly in previa? So what? It still depends on what type it is. If it is type 1, A and B, and type 2A, it is vaginal delivery. What are you trying to ask me, Mysore? If it is major degree, irrespective of whether it is anterior or posterior, we'll still do a cesarean section. Okay, till Mysore actually writes what they want to know, I'll go ahead. So I'm saying there is something called as a double setup. No, it will not. I will come to your question a little while later, Mysore. So coming to a double setup examination in placenta previa. Now, what is this double setup examination? So sometimes what happens is that either the facility of ultrasound is not available, right? Or the patient comes directly in labor and she comes with APH. Now we don't know whether she is minor degree of placenta previa or she is major degree of placenta previa. Then in that case, so that means if a patient is coming at term in labor with APH and we don't have the facility for ultrasound with us, so that means we don't know whether she is minor or major. In that case, we take the patient to OT and do a double setup examination, by which we mean one table we do examination under, or on one table we do a PV examination, and on the second table we keep everything ready for an emergency cesarean section. Now, PV examination mein what are we trying to rule? So, if the PV examination, if during PV examination, the patient begins to bleed or we feel the placenta lying at the internal os, it means it is a major degree of placenta previa. And in that case, we shift the patient to the other table and quickly deliver her up by cesarean section. Whereas if we do not feel the placenta lying at the level of internal os and she does not bleed by our PV examination, that means the placenta is minor degrees. So in that case, we can very well do what kind of a delivery? Vaginal delivery for her, right? So this is nothing. So the other word for double setup examination is nothing but PV in OT. So we are trying to be safe and we are doing a PV examination in the operating theatre so that in case it turns out to be a major degree of placenta previa, we can immediately take her up for a cesarean section, right? Okay, so next thing what they are asking me is, so what they are trying to ask me is, what is the type of cesarean done? What is the type of cesarean done if it is an anteriorly located placenta previa, right? So please understand that in modern day we are trained enough to do even a lower segment cesarean section in placenta previa. So we can still do a cesarean section if we know the technique. We can deliver the baby without giving an incision on the placenta. So we incise the uterine wall, but we don't incise the placenta. We reach the membranes, rupture the membranes and deliver the baby, and then we touch the placenta. But yes, so in modern day obstetrics, we do only lower segment cesarean sections even for placenta previas. But yes, if we talk about the indication for classical cesarean, which is an incision on the upper segment. So classical cesarean is incision on the upper segment. Then yes, an anteriorly located placenta previa may, instead of giving the lower segment cesarean, we would give the classical scar, right? So that we don't cut open the placenta, because the moment you cut open the placenta, there is going to be fetal exsanguination and the fetus will die very early, very quickly. So, but as I said, we are trained enough to conduct deliveries even or cesarean sections, lower segment, even in the presence of placenta previa. But yes, as far as your MCQs are concerned, anteriorly located placenta previa could be one of the, I'm saying it not absolute indications, it could be one of the indications for a classical scar, right? So is your doubt sorted out, Mysore? Okay, the next thing we talk about is, we'll finish this topic and then we'll take a break, all right? The next thing we talk about it, what is the preferred mode of delivery? What is the preferred mode of delivery in abruption? Can anybody tell me? So in abruption, the preferred mode of delivery is vaginal. Now patients, no, it is not cesarean, it is a vaginal delivery which is the preferred mode of delivery in abruption. The reason is that patients with abruption progress very fast in labor. So these patients progress very fast in labor, and that is why the preferred mode is going to be a vaginal delivery. Now, indications for CS in abruption would remain the same. That is, if the patient is in shock or the baby is in distress. So whether when the patient is in shock or when there is fetal distress, even in cases of abruption, again the answer would be cesarean. But out of these two indications, I said that the preferred mode is going to be vaginal delivery, right? If a patient is of abruption, if the patient of abruption, I'm saying, goes into DIC, if the patient of abruption goes into DIC, then what is going to be the mode of delivery? And let's say the patient is a case of abruption, she has DIC and she also has fetal distress. What is the mode of delivery? Now that is what is the catch in the question here. Although I did write fetal distress, please understand, whenever a patient is in DIC, our mode of delivery is going to be vaginal delivery. These patients are very high risk for a cesarean section. Why? What happens is that you would give an incision on the uterus to deliver the baby. You will deliver the baby. But when you try and stitch back the uterus, every time you prick it, it is going to keep bleeding. So it will just not be possible for us to achieve the process of hemostasis. The patient will keep bleeding and eventually we may even have to do a hysterectomy. So whenever the word DIC is written, the preferred mode is going to be vaginal delivery. Also, along with this, what do? We try and correct DIC. How do we correct DIC? DIC is corrected by transfusion of fresh frozen plasma, right? So FFP. So DIC is corrected by giving fresh frozen plasma. Alright? So we give FFPs and we try and bring back or bring the INR, that is international normalized ratio, as close to normal. Right? So whenever this catch is there is fetal distress, but there is also a DIC, then again our preferred mode is going to be vaginal despite the fetal distress, because for us the primary concern is the mother. We first try and save the mother and then we think about the baby. See, we don't jeopardize the health or the life of the mother to save the life of the fetus. Right? So this is about antepartum hemorrhage. Any doubts you people have from APH? Any doubts you want to ask? Or else what we'll do is we'll take a 10-minute break. Yes? So no doubts. So we take a 10-minute break and we restart the class at 6:45. So it's almost 15 minutes, Bilaspur. We will restart the class at 6:45. Right? Okay. After the break, we finished antepartum hemorrhage, and the next topic again that we're going to take up is going to be one of the more important topics, and it's going to be preeclampsia. Right? So we start now with preeclampsia. What do you want to know about LSCS? We'll come and we'll talk about the details about what are the other indications for classical, as in when we, go ahead. Maybe we'll talk about it when we teach you labor, right? An indication of cerclage will also come when we do abortions. So please don't worry, we'll take them up. Don't do them out of the topic, because otherwise you will not get a hang of it. It should be done where it is relevant, only then it will make sense to you, right? Okay. So I said we'll take up cerclage when we do abortions, and we will take up classical cesarean when we do labor, right? We'll talk more in detail about it when we do those parts. See, bacha, don't get confused. Schultz is something that you use after delivery. You don't use the Schultz method before or in antepartum hemorrhage, right? We don't use that method or that definition in antepartum hemorrhage, right? And type 0 is one classification. Revealed and concealed is one classification. You cannot equate anything to anything, right? So those are two different classification systems that are used for the classification of, what do you call it? Classification of abruption. Alright, now before you give me more dictations, because type 2B, type 3 and type 4, they are major degrees because the placenta lies very close or in fact in contact with the internal os. And as a result of which the bleeding is going to be much more if the placenta is close to the or sitting on the internal os. Second reason, when the placenta is sitting on the internal os, you cannot deliver the patient via internal os because there is obstruction at the level of internal os. So since there is obstruction, the head will not go down. That is why in major degrees of placenta previa, when the os is covered by placenta previa, the mode of delivery has to be a cesarean section, right? Okay, so we begin with preeclampsia. And the first thing I would tell you is that earlier we used the term PIH, right? Earlier we used the term PIH, which stands for pregnancy-induced hypertension. PIH is not used nowadays. The terms that we use nowadays are preeclampsia, gestational hypertension. So first we'll talk about these two terms and then we go ahead with the next two terms. So there are a lot of understanding in this topic as well which is involved. So first we will define what is gestational hypertension, right? Now gestational hypertension is a blood pressure of more than 140 by 90 millimeters of mercury, a blood pressure of more than 140 by 90 millimeters of mercury beyond 20 weeks of period of gestation, beyond 20 weeks of period of gestation, and no proteinuria. So this is how we describe preeclampsia or gestational hypertension. So when the blood pressure is more than 140 by 90, beyond 20 weeks of period of gestation, and no proteinuria. So these are the three terms used to describe gestational hypertension. Please understand, pedal edema and weight gain. Pedal edema and weight gain are no longer criteria for diagnosis. They are no criteria for diagnosis of gestational hypertension or preeclampsia. We have removed these criteria now. So these are the three criteria we use for gestational hypertension. There is also a fourth criteria for gestational hypertension, and the fourth criteria is that the blood pressure will come back to normal. The blood pressure will return to normal within 12 weeks of delivery of the baby. So the blood pressure will return to normal within 12 weeks of delivery of the baby. Now we don't wait for the fourth criteria to be met. If the first three are met in pregnancy, then we make a diagnosis of preeclampsia, right? Then we make a diagnosis of preeclampsia, whereas, or gestational hypertension, whereas the fourth criteria is actually also true. So the blood pressure in gestational hypertension will come back to normal within 12 weeks. But all I am saying is we don't wait up till the postpartum time to see whether the blood pressure is coming to normal or not, and then make a diagnosis. So we will make a diagnosis when the first three criteria are met, and that is gestational hypertension. Now the ideal way of taking blood pressure in a pregnant female is also in the sitting position. So it is not left lateral, it is not semi-recumbent, it is in the sitting position. So sitting position is where or how we take the blood pressure even in a pregnant female. Also, when you are taking the diastolic blood pressure, when we are taking the diastolic blood pressure, which Korotkov sound should be taken in a pregnant female to measure the diastolic blood pressure? Yes, which Korotkov sounds should be used? Yes, disappearance of which Korotkov sound should be used as to pick up the diastolic blood pressure in a pregnant female? Is it Korotkov 4 or Korotkov 5? Which one? Now this is something very basic, but again it came in the exams. Yes, so in a pregnant female, yes, it has to be Korotkov 5. So we take the disappearance of the Korotkov 5 sounds as the criteria to take diastolic blood pressure. So this is how we define gestational hypertension. Coming to the next definition, which is preeclampsia. So I'm saying we have given away the term of PIH, and now the term we use is preeclampsia. So what is preeclampsia? It is gestational hypertension with proteinuria. So when there is a blood pressure of more than 140/90 and it occurs beyond 20 weeks and there is proteinuria, we call it as a case of preeclampsia. Now, how do you define proteinuria? The proteinuria here is defined as 300 milligrams or 0.3 grams. 300 milligrams or 0.3 grams per 24-hour urine sample. So it is not per liter, it is not per ml. It is in a 24-hour urine sample. The value of proteins should be more than or equal to 300 milligrams or 0.3 grams. And if we are using the dipstick method, then in dipstick method we say 1+ is the criteria to diagnose proteinuria. So 300 milligrams or 0.3 grams or 1+ on dipstick will be called as proteinuria, and together this condition is called as preeclampsia. Then we come to the term eclampsia. What is eclampsia? Eclampsia is preeclampsia plus seizures. So preeclampsia plus seizures is called as eclampsia. I am just giving you the definitions right now because there have been questions in the current exams where everything is based on the definition only, right? The next term we use is called as chronic hypertension. So how do we define chronic hypertension? So when the blood pressure is high, that is more than 140/90, before 20 weeks of period of gestation. So if the blood pressure is high, even before 20 weeks of period of gestation, or maybe even at conception, so any time before 20 weeks, it may be high when the patient conceives. Even if that time it is high, these conditions are called as chronic hypertension, right? Then there is a condition called as chronic hypertension with superimposed preeclampsia. Chronic hypertension with superimposed preeclampsia. Now what are the criteria for saying that a patient of chronic hypertension Now when she has become pregnant, she has developed preeclampsia. So that preeclampsia is called as superimposed because it is coming after or on the basis of chronic hypertension. So what are the criteria? The first criteria is, yes, so I'm coming to it. So first criteria is uncontrolled hypertension, right? So a patient whose blood pressure was earlier controlled, but when she becomes pregnant, the blood pressure starts to rise, right? So this is one of the criteria, uncontrolled hypertension, which was previously well controlled. Second, we say new onset proteinuria. The second criteria is new onset. Why are you going on to eclampsia, Mysore? We'll come to eclampsia. Let's go step by step. Why do you want to know the type of seizures? We'll do every single doubt of yours as we go ahead in the class. Don't rush on to things, right? So, new onset proteinuria is the second criteria, or we say worsening proteinuria. So, what does this mean? Now, this means that patient, when she was not pregnant, her blood pressure was high. But as soon as she becomes pregnant, now she develops proteinuria. So, that is one of the criteria. Second criteria, the patient, even before pregnancy, had high blood pressure, she had proteinuria. Why? Because hypertension would always cause nephropathy. So even before pregnancy, she had hypertension, she had proteinuria. But now when she becomes pregnant, the amount of proteinuria begins to increase. So that is called as worsening proteinuria. And the third criteria is a low platelet count. And what is considered as low platelet count? Counts less than 1 lakh. So counts less than 1 lakh would be called as low platelet count. So which means that a patient of chronic hypertension, when she develops pregnancy, her platelets begin to fall. So that is again one of the criteria to call chronic hypertension with superimposed preeclampsia. Now sometimes people also take end organ damage. Right? People also take end organ damage as criteria for superimposed preeclampsia. What do we mean by this? That a patient of chronic hypertension, when she becomes pregnant, she developed retinopathy, right? So that is a sort of end organ damage. So whenever there is development of end organ damage with the onset of pregnancy, you would again call it as what? Superimposed preeclampsia. Now, Jagdalpur and what center is that? Devangri. Now you people are answering each other's query. I have not gone to HELP syndrome. Why are you jumping on to HELP syndrome? What happens if I start, quickly reaching on to things like you are doing? Please don't think that these definitions are not important. Do you know what has come this year in AIMS 2014? May AIMS? This very thing that I am teaching you right now. So chronic hypertension with superimposed preeclampsia, its definitions or these criterias was the latest MCQ in AIMS 2014, right? So every single thing that we are telling you has an importance, right? So listen to it very carefully. I will come on to everything that you're trying to write. I'm trying to, give you everything. So don't rush up on things. So this is the definitions of the terms that we use now in preeclampsia. Theek? Then the next thing we talk about is what are the risk factors for preeclampsia. What are the risk factors for preeclampsia? So first, preeclampsia is more common in, not nulliparas, I will write it as primigravida. So preeclampsia is more common in primigravidas. It is not common in multigravidas, right? Diabetes mellitus is a risk factor for developing preeclampsia in pregnancy? Chronic hypertension is a risk factor for developing preeclampsia in pregnancy. Renal disease is again a risk factor for developing preeclampsia in pregnancy. Obesity is again a risk factor for preeclampsia. Again, APLA syndrome, antiphospholipid antibody syndrome, is one of the risk factors for preeclampsia. Twin pregnancy is a risk factor for preeclampsia. Molar pregnancy is again a risk factor for preeclampsia. So these are the various risk factors of preeclampsia. Can you tell me one protective factor? Can you tell me one protective factor for preeclampsia? Anybody? So very surprisingly, yes, Agartala is absolutely right. Very surprisingly, smoking is a protective factor. The exact mechanisms are not yet known, but it is seen that smoking is a protective factor for preeclampsia, right? Also, placenta previa. Also, placenta previa is seen to be a risk factor for preeclampsia. Now, Bikaner, what are you trying to ask me? Are you asking me what is molar pregnancy? Are you asking that? Yes. Okay. Molar pregnancy is a kind of a pregnancy where there is abnormal development of the placenta. There is abnormal development of the placenta. The cells which form the placenta, they start multiplying like a tumor, right? The cells of the placenta start multiplying like a tumor, and that is resulting in the formation of a molar pregnancy. We will do molar pregnancy as well as time goes by. Yes? Theory. Right. As I said, what are the exact mechanisms? How smoking is preventing preeclampsia? We don't know. There are no exact theories to give us how it is protecting. Probably to do something with the placental hormones or the hormones of pregnancy, which is mediating this effect, right? Now, next thing we talk about is what is the pathophysiology, or how is. No, I told you cerclage is not done in antepartum hemorrhage. Not at all. We don't do cerclage in antepartum hemorrhage. So now we come to what is the pathophysiology in pregnancy that leads to preeclampsia, right? Now, as I said, there are certain cells in the placenta. These cells are called as cytotrophoblast. There are cells yes, placenta previa is a protective factor. I said it has been seen to be a protective factor for preeclampsia. So usually the two do not coexist, right? That is what I am trying to tell you. So talking about the pathophysiology, now there is a cells in the placenta called as cytotrophoblast. Now normally what happens in any pregnant female, these cells, or there is another type of cytotrophoblast called as extravillous. So when you talk about cytotrophoblast, there are villous cytotrophoblast and there are extravillous cytotrophoblast. The villous cytotrophoblast are ones which take part in the formation of placenta, right? So villi or the villous cytotrophoblast are the ones which take part in the formation of placenta, Whereas what do the extravillous cytotrophoblasts do? They invade the maternal blood vessels. So they invade the myometrium and then they invade the maternal blood vessels. This is what I am talking about. Normally, in any pregnant female, this is going to happen. When they invade the blood vessels of the mother, they make these blood vessels resistant to vasopressors. They make these blood vessels resistant to vasopressors, which means if there is a blood vessel and it is lined by these extravillous cytotrophoblasts, right? Then even if a vasopressor is going to come, for example, renin comes or angiotensin comes, then this blood vessel will not constrict. It will remain in a dilated manner because of this coating of this extravillous cytotrophoblast, right? So this mechanism occurs in normal pregnancy so as to ensure good uteroplacental blood flow. Why? Because if there is good uteroplacental blood flow, it ensures good oxygen supply to the fetus. Now we will see what is happening in patients with preeclampsia. Now in patients who develop preeclampsia, it is seen that there is no invasion. There is no invasion by these extravillous cytotrophoblasts. So what happens? The blood vessels now do come under the effect of vasoconstrictors and they undergo vasoconstriction. Vasoconstriction in turn does what? It does endothelial injury. So there is endothelial injury. Once there is endothelial injury, it predisposes to what? It causes movement of fluid from intravascular compartment to extravascular compartment, and therefore we see that patients with preeclampsia usually have what? Edema. So they are edematous. This is the reason why they develop edema. Also, if there is endothelial injury, what does it lead to? Platelet activation. What will platelet activation do? There is formation of clots or thrombi. In turn, what do the thrombi do? They will cause infarction. And this ischemic injury will occur at all organ levels. The ischemic injury is going to occur at the level of all organs. And this ischemic injury also occurs at the level of placenta. So many organs are affected. The placenta itself is the cause and it is also being affected. Then kidneys are affected, liver is affected, brain is affected. So there is going to be ischemic injury to all these organs. Eyes are affected, right? Now placenta, if it becomes ischemic, whatever part ischemic becomes ischemic, stops functioning. As a result of which, what will happen? There is going to be decreased uteroplacental blood flow. And once the blood flow to the baby decreases, once there is decreased uteroplacental blood flow, the oxygen supply to the baby also decreases, and this results in a baby which becomes growth restricted or undergoes intrauterine growth restriction. So that is how all end organs are being affected. The placenta, the baby, kidney, liver, brain, eyes, right? So all these organ systems are being affected because of endothelial injury, This endothelial injury is occurring because there is loss of invasion by extravillous cytotrophoblast. So if I ask you what is the primary event which is the cause, it is the loss of these extravillous cytotrophoblast which should have normally invaded the maternal blood vessels, right? So this is the pathophysiology of what is happening in preeclampsia. Next thing we talk about is, can we do something for these patients? Can we do something for these patients in order to protect them from developing preeclampsia? So various theories are there. The theories say reduce salt intake. So a lot of people would say reduce your salt intake and it will reduce the chances of preeclampsia. Then a lot of people will say, since there is endothelial injury, please consume antioxidants, right? So since there is ischemic injury, consume antioxidants and it will prevent against preeclampsia. For example, they'll say take vitamin C, take vitamin E. Then fish oils, which are rich in omega-3 fatty acids. And then a lot of people also say calcium supplementation is going to be effective. Now we have to understand that none of these have any role in protection of preeclampsia. None of these things have any role in the protection of preeclampsia. Only thing which can be given to prevent preeclampsia is low dose aspirin. It is going to be low dose aspirin. Okay, Hubli is saying ask the patient to smoke. Now being doctors, you can't do this. We can't ask the patients to smoke because the risks outweigh the benefits. Just because we know it might prevent preeclampsia, it can lead to a lot of other complications in pregnancy, right? But I like it. Ask them to smoke. Okay. So the only drug which can be given to prevent preeclampsia is low dose aspirin. And when we say low dose, how much should be given? 75 to 80 milligrams. 75 to 80 milligrams given daily starting from 12 weeks. Starting from 12 weeks, right? Okay. Calcium supplementation could be the next best answer. If aspirin is not in the options, then calcium supplementation could be the next best answer. Why? Because it is seen to be effective in populations which are calcium deficient. So it doesn't have a role in every pregnant lady. Only if the lady belongs to a geographical area where there is calcium deficiency, then yes, calcium supplementation may have some role. But otherwise, calcium supplementation in every pregnant woman has no role in prevention of preeclampsia. So if the blood levels of calcium are normal, then calcium supplementation would not help. Now, on the other hand, you will find very often every pregnant lady being prescribed calcium. Why do we prescribe calcium? Are we doing this to prevent preeclampsia? All pregnant women are prescribed calcium. In fact, you get it as an MCQ as well. What is the calcium requirement in pregnancy? Although these things come in PSM, where they give you all the recommended daily allowances. Ma'am, and which? No, it is not 1500 milligrams. The calcium requirement in pregnancy is 1000 milligrams. It is 1000 milligrams. Now, what is Kolhapur asking me? What about estrogen effect are you asking me? What are you asking me? And what is Bareilly asking me? In which patients we give? What are you writing? Aspirin. Is that what you are asking me? The invasion starts in or occurs in two phases. It begins very early in pregnancy. So we say that the invasion occurs in two phases. One would be in the first trimester, and the second invasion occurs at 14 to 16 weeks of pregnancy. So there are two sets of invasions or two phases of invasion. One invasion begins, or the first set of invasion begins in the first trimester itself, and the second invasion, which is completed by 14 to 16 weeks of period of gestation. How does aspirin help? You tell me, how does aspirin help? Aspirin prevents vasoconstriction. It also prevents endothelial damage by the platelets, right? So that is how it helps. Yeah, so calcium is required because there is a lot of bone loss in pregnancy. There is a lot of bone because of the increased demands. More and more calcium is being diverted to the baby. So the female herself becomes calcium depleted. And that is why, that's the reason why we supplement calcium in every female who is pregnant. So it is not for prevention of preeclampsia, right? Now another thing which you would find in patients with preeclampsia is hemoconcentration. Yes. Now what is hemoconcentration? Or can you tell me why? Now just a few minutes back we said that there is endothelial injury and there is movement of, no, it doesn't cause premature closure, right? So hemoconcentration kaise explain hote hain? We said that there is movement of fluid from the intravascular compartment to the extravascular compartment. As a result, the number of blood cells in the blood vessels increases, and patients with preeclampsia show hemoconcentration. So we say it's both. We can't say whether it is the invasion of the first or invasion of the second. It is just seen that there is no invasion at all of extravillous cytotrophoblast in patients with preeclampsia. Yes, so plasma decreases more as compared to red cells, so there is hemoconcentration, and as a result we say hemoconcentration is one of the predictors of preeclampsia. It is one of the predictors of preeclampsia. That means, now what happens is, normally in every pregnant female, normally as a normal physiological change, in every pregnant female, what happens? There is hemodilution. So there is hemodilution normally in pregnancy. But in patients of preeclampsia, they never show this hemodilution. Instead, what they show is hemoconcentration. So if we see a female whose hemoglobin does not fall in pregnancy and rather the values keep coming as 14 grams, 15 grams, then it is, we say, one of the predictors that the patient may develop preeclampsia later in the pregnancy, right? A second predictor of preeclampsia is rollover test. So I'm now telling you the predictors. So first I said is hemoconcentration. Second I am saying is the rollover test. Now in rollover test, what do? We first take the blood pressure of the patient in left lateral position. Then we roll her over to her back. So we make her supine, and after 5-10 minutes we again take the blood pressure. Now normally what should happen if a patient is not preeclamptic or will not develop preeclampsia? What should happen? The blood pressure should normally fall when she is supine. in a normal pregnant female, the blood pressure should fall when she is made supine. Why? Can you tell me why the blood pressure should fall? Anybody? Why should a blood pressure fall in a pregnant female when she is made supine or when she is made to lie on her back? So the reason is because the gravid uterus compresses the inferior vena cava. The gravid uterus compresses the IVC. So there is decrease in venous return, which causes a decrease in the cardiac output and which causes a decrease in the blood pressure. On the contrary, this thing will not be seen in patients with preeclampsia. On the contrary, when we do the rollover test in patients who may develop preeclampsia later, in them the blood pressure rises. When you make them supine, the blood pressure rises because of the increase in the afterload. So the blood pressure rises. So this is called as a second predictor of preeclampsia. Third, again I am talking about predictors of preeclampsia. The third predictor is hyperhomocystinemia. So it is seen that the homocysteine levels in these patients are higher as compared to normal pregnant females. So there is hyperhomocystinemia. Fourth predictor is uric acid. So serum uric acid levels are higher in patients who may develop preeclampsia. Serum uric acid levels are higher in patients who may develop preeclampsia. So that's what the change is. These patients have abnormal responses. So patients who tend to develop preeclampsia, they have abnormal responses to these changes. As a result, we don't see a fall which should normally happen in any pregnant female. Rather, there is a rise because I told you there is an increase in the afterload, and as a result of which the blood pressure rises because of the pressure and the vasoconstriction of the blood vessels. So the blood pressure in these patients, instead of falling, it rises, right? So next we said was hyperhomocystinemia, and still next we said was uric acid. The next predictor of preeclampsia is going to be the next. For any further details, you'll have to refer to your physiology books, right? If you are not understanding the changes in the physiology, you'll have to go back and understand. See, don't ask why for everything. Why hyperhomocystinuria? These are associations which have been found. We don't have any reasons for this, right? It is an association which is found that patients with preeclampsia have a higher homocysteine level as compared to normal population. So it's an association. There is no why to it, right? Similarly, you will ask me why uric acid. So it has been seen that patients, that is why they are called as predictors. It has just been seen that patients who will develop preeclampsia later in the pregnancy will have higher uric acid levels as compared to the normal pregnancy, right? Okay. Then we come to next predictor, which is called as, or which is said as, there is increased calcium excretion in the urine. So in patients who tend to develop preeclampsia later in the pregnancy are seen to have a higher calcium excretion in pregnancy. They are said to have a higher calcium excretion in the urine. No, aspirin cannot be given before 12 weeks. All drugs are contraindicated in the first trimester. See, you have to weigh the risks and the benefits. We can't give aspirin in the first trimester. We start aspirin after 12 weeks only. That is why that is the earliest time we should give it. If we don't give it by 12 weeks and you say we will give it after 20 weeks, then it has no effect on prevention. So it has to be given as early as 12 weeks, probably because then it will prevent the second invasion, but the first invasion would have not occurred by that time, right? But as I said, you have to weigh the risks over the benefits. We cannot give aspirin in the first trimester, right? It is not safe for the developing fetus. Now, once we've talked about the predictors of preeclampsia, the next thing we come to, how do we define or different types of preeclampsia, right? Now, different types are called as mild preeclampsia, and then there is a severe preeclampsia. Now, when you talk about mild and severe preeclampsia, please understand there is no term as moderate. So, it is not mild, moderate and severe. It is only either mild or only severe preeclampsia. Now, what are the differences between the two? Again, this is the table from which a lot of MCQs are going to be asked, right? So, mild may the blood pressure is more than 140 by 90 millimeters of mercury, whereas severe may the blood pressure is going to be more than 160 by 110. Okay, severe may the blood pressure is going to be more than 160 by 110. Mild may proteinuria was how much? 300 milligrams or 0.3 grams in a 24-hour urine sample. Whereas in severe preeclampsia, the proteinuria is as high as more than 5 grams in a 24-hour urine sample. In severe preeclampsia, there is going to be oligohydramnios and there is going to be IUGR, whereas these features are not seen in mild preeclampsia. So, oligo and IUGR are not features of mild preeclampsia simply because the disease is not that severe in order to cause a reduced uteroplacental blood flow to cause IUGR, right? Fifth is serum creatinine. The serum creatinine levels in severe preeclampsia are raised and they are more than 1.2, whereas serum creatinine levels would be normal in mild preeclampsia. The patients with severe preeclampsia have higher tendency to develop pulmonary edema. They have higher tendency to develop pulmonary edema, again which is not seen in mild preeclampsia. Seventh, patients with severe preeclampsia develop the HELP syndrome, right? What they were talking about a few minutes back. So, patients with severe preeclampsia develop HELP syndrome, in which H stands for hemolysis, EL stands for elevated liver enzymes, and LP stands for low platelet count. And LP stands for low platelet count. Right? So this is a feature of severe preeclampsia, again not seen in mild preeclampsia. Lastly, the difference point is visual disturbance. Visual disturbances are again seen only in severe preeclampsia. They are not seen in mild preeclampsia. They are not seen in mild. They will be seen only in severe preeclampsia. Cause of HELP. I told you there is ischemic injury to all these end organs. That is what is leading to end organ damage in various forms. So in kidney it presents as proteinuria. In liver it can present as hemorrhage. It can present as HELP syndrome. We'll come to what are the details of visual disturbances that can occur. So these are all resulting. The pathophysiology is, everything is going to be the same. There is vasoconstriction. There is going to be endothelial injury. There is release of inflammatory mediators, all of which together produce these end organ damage, right? Now, there is another term which is called as impending eclampsia, right? So there's another term which is called as impending eclampsia. Now, as the term implies, impending, मतलब अभी होने वाला है. So, impending eclampsia means eclampsia can occur any time, although it is not occurring right now, but it can occur. So, you are frequently asked, yes, I'm coming to that. Frequently asked, what are the signs and symptoms of impending eclampsia? Ludhiana, I'm coming to what you're asking, right? So, first symptom is described as nausea, vomiting, and epigastric pain. Nausea, vomiting, and epigastric pain. Now, these symptoms which occur, they are because of stretching of the liver capsule. There is stretching of the Glisson's capsule or the liver capsule, which occurs because of formation of subcapsular hematomas. And then this stretching of the capsule is what produces nausea, vomiting, and epigastric pain. So these are the first kinds of signs and symptoms with impending eclampsia. The second type is going to be headache and dizziness. The cause of this headache and dizziness is cerebral hypoxia. The cause here is cerebral hypoxia, which manifests in the form of headache and dizziness. The third symptom is visual disturbances. Now, what are the visual disturbances that occur? The visual disturbances are in the form of diplopia, blurring of vision, scotomas, and even blindness. So there can be diplopia, blurring of vision, scotomas, and even blindness. Now, what is the cause of blindness? So the most common cause of blindness is hypoxia to the occipital lobe. So it is central in origin. The most common cause of blindness is hypoxia to the occipital lobe. So therefore we say it is central in origin. And the second common cause of blindness is retinal detachment. In fact, because the most common cause is central, which is occurring because of hypoxia, we say alright, hold on, right? So despite, or what I am saying is, there is, since this change is because of hypoxia to the occipital lobe or to the central in origin, and since the cause is hypoxia, that is why we say that this blindness is reversible, right? This blindness is reversible. So when the patient delivers, the eyesight returns, right? So since it was only because of hypoxic injury, quite a lot of times the eyesight returns to normal after delivery. Now what is Hubli asking me? How to differentiate severe eclampsia with eye change and impending eclampsia? Now when you say how to differentiate, so for that you'll have to go back. Yes, severe, I'm telling you, go back to your ophthal books, and there was a classification of hypertensive retinopathy called as Keith-Wagner's classification. So please go back and read that classification. No, retinal detachment is not completely reversible. So the one that is more reversible is that which occurs due to occipital lobe hypoxia, right? Yes, so what I was saying is, in your ophthal books you will find a classification called as Keith-Wagner's classification. Please read that, and that gives you the severity of the changes in the retina. I can just give you the last point, or which is the most severe, which occurs as terminal event. That will be seen as silver wiring, something that was called as silver wiring, and papilledema. So if you see these changes, then you must know that these changes are due to severe preeclampsia. So this was the last stage in the Keith-Wegner's classification, right? So silver wiring and papilledema are one of the terminal events, or what is seen with impending eclampsia, or most severe form of preeclampsia, right? So these are the signs and symptoms of impending eclampsia. Now, if you talk about the treatment of preeclampsia, there can be two kinds of treatments, right? There can be two types of treatments. The first one is going to be symptomatic, and the second is one which is specific to preeclampsia. Now, what would be the symptomatic treatment? Symptomatic treatment is what we would do in the form of controlling of blood pressure and prophylaxis for seizures. So when we do these two things, we say we are doing symptomatic management, that is control of blood pressure and prophylaxis for the seizures. Now, so I'll go to specific management later. We'll first take up symptomatic management. Now, the reason we want to give symptomatic management is to reduce the morbidity of the mother. Okay, to reduce morbidity of mother. Why? Because if we don't control the blood pressure, what will happen? She may develop cerebrovascular accidents, cerebral hemorrhages, right? And further end organ damages. So we want to control the blood pressure of the mother in order to reduce the morbidity of the mother. Coming to what are the indications to start blood antihypertensives? What are the indications to start antihypertensives? Number one, any patient who has a blood pressure of more than 160 by 110, or rather, let me give it to you the other way. Any time when the diastolic blood pressure, is persistently more than 100 millimeters of mercury. So this would automatically include all patients of severe preeclampsia where the blood pressure is more than 160 by 110, right? So first I'm saying, the first point is, when the diastolic blood pressure is persistently more than 100 mmHg. The second indication is all patients of impending eclampsia. So irrespective what is the blood pressure of the patient, if there is impending eclampsia, it is an indication to start antihypertensive therapy. Now once we say we are going to start antihypertensive therapy, what all should we know? The drugs which can be used for the same. So what are the drugs which can be used? What are the drugs which can be used for control of blood pressure? Now we give it in the form of drug of choice. So what is the drug of choice for preeclampsia? No, now the things have changed, Haldwani. Methyl dopa is not the drug of choice, right? So drug of choice for preeclampsia now is labetalol. It is labetalol. Now when you talk about labetalol, it comes in the form of tablets. It comes in the form of tablets, and the dose is 100 milligram BD. So the starting dose is 100 milligram given twice a day. Next they will ask you, or it is very important from MCQ point of view as well, what is the drug of choice for chronic hypertension? So when they specifically say chronic hypertension, then the answer is still methyl dopa or aldomet. So it comes by the name of aldomet or methyl dopa. So methyl dopa is the drug of choice for chronic hypertension, whereas labetalol is the drug of choice for preeclampsia. Then the third type of thing is, what is the drug of choice for hypertensive emergency in preeclampsia? What is the drug of choice for hypertensive emergency in preeclampsia? The answer now is again IV labetalol. The drug of choice for hypertensive emergency is IV labetalol. How much do we give? 20 milligrams is given initially, intravenous. We wait for 20 minutes. We wait for 20 minutes and we again take the blood pressure. If the BP is still high, the next dose is 40 milligrams. Wait again for 20 minutes. If still high, the next dose is 80 milligrams and the next dose is still 80 milligram. So by this, you are also asked, what is the maximum dose of IV labetalol? What is the maximum dose of IV labetalol which is given in a day, or which can be given in a day? The answer is 220 milligrams. The maximum possible dose of IV labetalol that can be given in a day is 220 milligrams. The second drug which is approved for hypertensive emergency in pregnancy is hydralazine. So the first best answer is IV labetalol. The second answer is hydralazine. So even hydralazine can be given for hypertensive emergency. Now the only drawback of hydralazine is that it causes much more reflex tachycardia. Labetalol does not cause that much reflex tachycardia. Hydralazine causes reflex tachycardia. Also, we should know that the control of blood pressure is faster with labetalol. So the onset of action is faster for labetalol. That is why now we say that the first drug of choice is labetalol, but IV hydralazine can also be given. The other drugs which can be given in hypertensive emergency are now there is a new drug which is called as diazoxide, and it can be given only for hypertensive emergency. Otherwise, it is not given in pregnancy. Now that becomes the next important question. What are the drugs or antihypertensive drugs contraindicated in pregnancy? Yes, what are the antihypertensive drugs contraindicated in pregnancy? ACE inhibitors. ACE inhibitors are contraindicated. ACE inhibitors are contraindicated. Second, beta blockers are contraindicated. Beta blockers are contraindicated. Third, diuretics are contraindicated. Now when we are saying contraindicated, we are using these drugs, or we are saying they are contraindicated for control of blood pressure. There may be some life-threatening or life-saving. These may become life-saving in a patient with heart failure. So I'm not there, the indication is different. All I am saying is these drugs are not given as antihypertensive agents in pregnancy. There may be more severe reasons for which you may be giving them. So like diuretics, we can give in CHF in pregnancy, but we are not giving it for control of blood pressure. So ACE inhibitors, beta blockers, diuretics. Nitroprusside is contraindicated because it produces cyanide toxicity. So nitroprusside is also one of the contraindicated drugs in pregnancy, right? The next thing which you should also know is, what is our goal of blood pressure? कितना नीचे लाना है blood pressure को? Now, अगर मैं कहूं कि मैंने अपने patient का blood pressure कम करके 110/70 कर दिया, is it a good control? Have I achieved good control in pregnancy? Yes, so the answer is no. Why no? Because as I told you, that patients of preeclampsia already have what? They have a low intravascular volume. If you further reduce the blood pressure, what is going to happen? You're going to reduce the cardiac output, and in turn you're going to reduce the uteroplacental blood flow. And such low blood pressures would cause IUD. Therefore, our goal of maintaining the blood pressure is a systolic blood pressure of 140 to 150 millimeters of mercury, and the diastolic blood pressure between 90 to 100 millimeters of mercury. So this is our goal. We don't go below that, because if we go more lower than this, then what is going to happen? There is going to be a decreased uteroplacental blood flow. Right? So this is about the antihypertensive therapy that we are talking about. When should it be given? What are the drugs that are to be given? And what are the drugs that are not to be given? Right? The second symptomatic management was prophylactic magnesium sulfate. Now what you have to understand is, all patients with severe preeclampsia, should be given prophylactic MagSulf. So now tell me, would you give prophylactic MagSulf in HELLP syndrome? Would you give prophylactic magnesium sulfate in HELLP syndrome? Yes. So the answer is yes. So even patients with HELLP syndrome should receive prophylactic MagSulf. We'll come to the details of magnesium sulfate just in a few minutes from now when we start eclampsia, right? Now, yes, so steroids. Now, Mysore is asking me, no steroids, or what is that? Probably what they want to ask, what is the role of steroids? So, do we give steroids in severe preeclampsia? Yes, we do give steroids if the fetus is less than 34 weeks, as I told you. So if the baby is preterm, steroids are given. So steroids can be given if the baby is less than 34 weeks for fetal lung maturity, right? The next thing we come to, so this was the symptomatic management. Talking about what is the specific management. Now, can you tell me what is going to be the specific management? Magnesium sulfate for prophylaxis against development of seizures. So whenever we say prophylactic, again we are going to give it as a prophylaxis for the development of seizures. We'll talk about more about MagSulf in just a few minutes from now. What is the specific management for preeclampsia? Delivery. Very good, Hubli. Because I just told you that the problem in now Now, guys, stop fighting on the chat box with each other, right? Don't fight with each other. That's not nice. Relax. So when we talk about specific management, what do we want to know? That the fault, what was at fault? Placenta was at fault. So the only management of preeclampsia is going to be delivery, right? So when you take out this pathological placenta, the process will stop. Otherwise, nothing can stop the process of preeclampsia. Antihypertensive cannot stop the process of preeclampsia. Magself cannot stop the process. The only thing that can stop it is delivery, right? So the optimum or the specific management for preeclampsia is going to be delivery of the fetus. Talking about eclampsia now. So we said, no, I will come on to the details of delivery also. First, let me finish what I am trying to tell you. Now we talk about eclampsia. And when you say eclampsia, then what was eclampsia? Eclampsia was preeclampsia, which is accompanied by seizures. Now I come to your question of what kind of seizures are these. So these are GTCS, generalized tonic-clonic seizures, also called as grand mal seizures, right? So generalized tonic-clonic seizures or grand mal seizures. The seizures are divided into antepartum, intrapartum, and postpartum. So you call them antepartum seizures if they occur for the first time before delivery. Intrapartum if the seizures occur for the first time during labor or delivery. And postpartum if the seizures occur for the first time after delivery of the baby. And the most common out of these three is antepartum eclampsia. Alright, the most common out of these is antepartum eclampsia. Now, what is the problem with eclampsia is that when the patient is, please wait, I am going to come on to the MagSelf part as well. So when a patient is throwing seizures, what all can happen? Now during the time of the seizure activity, there is complete cutoff of the uteroplacental circulation because of the contractions and increased vasoconstriction. Second, the patient may have a fall and suffer from trauma. She may suffer from head injury. Third, the patient may aspirate the secretions. That could be the other thing. So the eclampsia, if you think of, is a life-threatening condition. Okay, eclampsia is a life-threatening condition, and therefore we have to quickly control it if a patient is throwing seizures. And how do we manage, or what do we do if a patient is throwing seizures? So the first thing we are going to do is stabilize the patient, secure the airway. So by stabilizing the patient, you maybe mean that you have to, many times you have to tie the patient to the bed, because the patient might throw herself out of the bed and then suffer from severe head injuries, right, or injuries to other vital organs. So you have to stabilize the patient, secure the airway. Once you are done with the airway, then the next step is giving magnesium sulfate. So magnesium sulfate is the drug of choice for seizures in pregnancy. So for eclampsia in pregnancy, the drug of choice is not diazepam, it is not anything else. The answer is going to be magnesium sulfate, right? Hubli, what are you trying to ask me? Intrapartum doesn't mean during second stage of labor. It means any time during the process of entire labor, not only the second stage. So, anytime during labor, it is intrapartum. Anytime before labor, it is antepartum. Anytime after labor, it is postpartum. Now, mag sulf has a central action. How does it control and how is it an anti-seizure drug? No, we don't give rectal diazepam, nothing at all. The answer is magnesium sulfate. Whoever is telling you that doesn't know how to manage eclampsia, right? No role of rectal diazepam and so on and so forth. What is the drug of choice? It is magnesium sulfate. What is the mechanism? It acts centrally. So it acts on the brain, and the receptors on which it acts is NMDA receptors specifically. Right? Now, mag sulf is given in what form? It is given as a loading dose, which is then followed up by the what are you writing? How do we treat the edema? We don't treat the edema in pregnancy. If it is pulmonary edema, it is all symptomatic management. Otherwise, we don't treat edema. Now, please don't forget that edema is a physiological finding as well. Pregnant females normally suffer from edema. So, you don't treat the edema or you don't give any drugs for the management of edema. Right? So, there is a loading dose and there is a maintenance dose. So, the loading dose is what we give initially, and it is 4 grams of mag sulf. What is the regime that we follow? The name of the regime is Pritchard. The name of the regime we follow in India is Pritchard, Pritchard. In this, we give first the loading dose and then we give the maintenance dose. The loading dose is 4 grams of magnesium sulfate given slow IV over 10 minutes. Alright, the minimum rate should be 1 gram per minute. But preferably we say we give it slow IV over 10 minutes. After this we give, so loading dose is 4 grams IV plus 10 grams of magnesium sulfate, 10 grams of magnesium sulfate given as 5 grams intramuscular in each buttock. So the total intramuscular dose is 10 grams, out of which 5 grams is given in the one buttock and another 5 grams is given in the other buttock, right? So therefore the total loading dose becomes 14 grams, out of which 4 is given IV and 10 is given IM. Now once we give the loading dose, then the maintenance dose is given every 4 hourly. Right? So after this we say, once you give the loading dose, we give the maintenance dose every 4 hourly. And before we give this dose 4 hourly, we are supposed to check for 3 things. The 3 things that we check are, number 1, knee jerk, or for that matter, deep tendon reflexes. Second thing that we check is respiratory rate. And the third thing we check for is urine output. So the knee jerk should be present. The respiratory rate should be more than 12 per minute. And the urine output should be more than 30 ml per hour. Right? So before you give the maintenance dose, we have to check for these 3 things. And once these 3 things are met, then only we can give the maintenance dose. Now what is the maintenance dose? It is 5 grams given intramuscular. the maintenance dose is 5 grams given intramuscular in alternate buttock. So by which we mean, for the first time they say we are giving 5 grams on the right side, then after next 4 hours 5 grams is given on the other side. This is because Maxalf injection is a very, very painful injection. It can also lead to abscess formations and induration. So that is why every time you have to change the site of injection, right? Now up till what time do we give it? So up till when? Up till when do we give magnesium sulfate? So we define it as Maxalf is to be given 24 hours after delivery or 24 hours after the first fit, whichever is later. So 24 hours, so the last dose of Maxalf has to be 24 hours after delivery of the baby or 24 hours from the first seizure that the lady has thrown, whichever is later. So this is the time how we decide up till what time are we going to give magnesium sulfate. Please remember, whether you give prophylactic Maxalf or you give therapeutic Maxalf, no matter what you are giving, for both these conditions the regime is going to be the same. So whether you give it prophylactically or you give it therapeutically, the regime is same. Now, what are the therapeutic levels of magnesium sulfate? They are 4 to 7 milliequivalents. Very good, Mysore. Yes, the therapeutic levels are 4 to 7 milliequivalents. और ये जो हम 3 चीजें चेक कर रहे थे before giving the maintenance dose, that is knee jerk, respiratory rate and urine output. Why are we checking these things? Why are we checking these things in our patient? Tanda, I'll come to your question first, answer mine. Why are we checking the urine output, the respiratory rate and the patellar reflex or the knee jerk? Now this we see to look for Maxalf toxicity. So we want to see that the patient is not developing magnesium sulfate toxicity, right? So these are the 3 things we see. If you are specifically asked at what level, at what blood level does the patellar reflex disappear? So the patellar reflex disappears at 10 milliequivalents. The patellar reflex, very good, Mysore, at 10 milliequivalents. There is going to be a respiratory arrest at levels more than 12 milliequivalents. So respiratory arrest कब हो जाता है? At 12 milliequivalents. And there is going to be cardiac arrest at levels more than 30 milliequivalents. So cardiac arrest, respiratory arrest and the patellar reflex is the first thing to go at 10 milliequivalents. Now what is the antidote? If there is magnesium sulfate toxicity, then what is the antidote? So first you should know, for example, I want to give the maintenance dose, right? And if any of these 3 things is absent, that is patellar, respiratory rate or urine output, if any of these is absent, I don't give the maintenance dose. So maintenance dose is to be stopped. Serum blood levels of magnesium are to be sent. And if they are high, we are supposed to give the antidote. And very correctly said, the antidote is going to be calcium gluconate. How much? 1 gram. How do we give it? We give 10 ml of 10% calcium gluconate IV. Now, this is because at the periphery, Magsalf also acts on the calcium channels and it prevents the inflow of calcium. That is why the antidote is calcium gluconate. Right? Now talking about delivery. Now you have to understand, all patients with preeclampsia, have to be delivered at 37 weeks, right? So at 37 weeks, we are going to induce labor in these patients, right? So they have to be delivered beyond 37 weeks. Second point is the preferred mode of delivery. The preferred mode of delivery is vaginal for both eclampsia and preeclampsia. The preferred mode of delivery is going to be vaginal delivery, right? Third important point. Like I said, patients of preeclampsia can be or have to be delivered by 37 weeks. We say patients of gestational hypertension. Patients with gestational hypertension can be taken up till 40 weeks, which is what their EDD. EDD stands for expected date of delivery. So patients who do not have proteinuria and their blood pressure is well controlled, so well controlled gestational hypertension. So I'm going to add this term to, you can write it completely. I've written patients of gestational, you should write patients who are well controlled and they are cases of gestational hypertension. They can be taken up to 40 weeks. Whereas preeclampsia has to be delivered by 37 weeks. The fourth important, then I said the preferred mode of delivery is vaginal. The fourth important point is, in case we are doing cesarean section, then the preferred route of anesthesia is spinal. So it is not GA. The preferred route of anesthesia for these patients is spinal anesthesia, right? Then for eclampsia we say delivery should be done within 24 hours. Delivery should be done within 24 hours of the onset of seizures. So this is the rule we follow for eclampsia. For eclampsia, I am saying the rule we follow is delivery should be done within 24 hours of onset of seizures. Finally, I am going to give you the indications of termination of pregnancy irrespective of period of gestation. हाँ बस करने वाले हैं, बस थोड़ा सा रह गया, last point. So what are the indications for termination of pregnancy irrespective of the period of gestation of the patient? So any patient who has impending eclampsia or signs and symptoms of impending eclampsia, their pregnancy has to be terminated no matter what is their period of gestation. They may be 28 weeks, they may be 30 weeks, they may be 32 weeks, right? Second indication, eclampsia. एक बार eclampsia हो गया, it calls for delivery. We cannot keep the patient on conservative management, right? Third indication, if the patient develops abruption. Now in abruption, I told you it has a very close relationship to preeclampsia. And if a patient develops abruption and there is fetal distress, again there is indication for termination irrespective of period of gestation. Fourth indication, HELP syndrome. So HELP syndrome is also one of the indications for termination of pregnancy irrespective of POG. Fifth indication for termination is uncontrolled blood pressure, or deranged kidney function tests. So if the kidney function tests are going on being deteriorated and her creatinine is going on rising, so rising serum creatinine would again be an indication for termination of pregnancy. Otherwise, what will happen? The patient will go into renal failure, right? So uncontrolled blood pressure which is not being controlled by drugs, or persistently deranged kidney function tests which are worsening. So instead of deranged, we should write worsening. So I'm changing the word here so that you don't get confused. We are going to write worsening of kidney function test, by which we mean if there is a rising serum creatinine level, then again pregnancy has to be terminated. Finally, we say severe oligohydramnios with severe IUGR. Severe oligohydramnios with severe IUGR is again an indication for termination of pregnancy. And the last indication for termination, irrespective of POG, is going to be reversal of blood flow on Doppler study. So we do Doppler study to see the blood flow in the umbilical artery. And if there is a reversal of blood flow in these umbilical arteries, then again it is an indication for termination irrespective of the period of gestation. Right? So with this we finish preeclampsia and eclampsia. Any doubts you want to ask me? What about DIC? Mysore, what do you want to ask about DIC? Yes, Mysore, what do you want to ask about DIC? Treatment of DIC. Why is calcium? I told you, because that is the mechanism of action of MagSelf, the magnesium sulfate at periphery. It blocks the calcium receptors, and as a result of which the calcium does not enter into the blood cells. So there is going to be a decrease of the calcium. So what we do is give calcium from outside in the form of calcium gluconate, right? Treatment of HELP. I said there is only one treatment of HELP syndrome, and that is delivery, because it is because of underlying pathology which is preeclampsia. So there is nothing else we can do for patients of HELP. So we manage them on conservative management. So we manage them symptomatically, and then it is delivery. So the only treatment of this is going to be delivery. I don't know when the next class is scheduled, but I think I'll take up labor now in the next class because I would need good time for that. Why spinal and not GA? Now the reason is that these patients have a very high risk of developing pulmonary edema. So that is why we don't want to give them GA. Second reason why we don't want to give them GA is that these patients have edema. So they also have laryngeal edema, and so intubation is difficult in these patients. The third reason why we don't give them GA is there is increased risk of postpartum hemorrhage in these patients, and again GA causes much more relaxation than spinal. So again there is an increased incidence of PPH. So overall, for multiple reasons, GA is not a safe route for them. The preferable route is spinal. What else? What is the other thing that you're asking me? What? Yup, ma'am. Scar in placenta previa? What about the scar? There is no scar in placenta previa. What scar are you talking about? Rotak, what points 1 to 4? What point 1 to 4 are you talking about? Oh, the management about delivery probably you're asking about, right? So the first point was this is for Rotak. Quickly write it down, Rotak. I'm saying I'll come on to the next. Your doubt, stop writing. Abhi Rotak, quickly likho. The first point was all patients of preeclampsia have to be delivered at 37 weeks of period of gestation. Second point was all patients of gestational hypertension who are well controlled. Patients with gestational hypertension who are well controlled can be delivered at 40 weeks or EDD, which is expected date of delivery, right? And the third point was the preferred mode of delivery is vaginal. The preferred mode of delivery is vaginal. Okay, so that was for Rotak. What else? Mysore, what do you want to ask me about DIC? Termination DIC, what do you mean by that? I said the management of DIC is transfusing them with FFPs, fresh frozen plasma, right? So by that, when you transfuse them with fresh frozen plasma, you're replacing them with the coagulation factor, so the INR would come back to normal, right? So that is what is the specific management for DIC. Then please tell us about classical scar and I will tell you about classical cesarean. Don't worry, I have not taught you anything about classical cesarean right now. It is you people who came up with that word. I introduced my words very, very carefully so as to give you the best possible explanations, right? So we will talk about classical cesareans when we talk labor, right? Don't be in a hurry to know about classical cesarean. What else? The starting part, Bareilly, they will put up the slides for you. What else? Other than that, what is your doubt? So they will repeat the slides after we finish the class, but any other doubts, anything else you want to ask me? What is plans, Bilaspur? What do you mean by plans? What plans are you talking about? Oh, please answer. What do you want me to answer about? Let me, Hubli, just hold on. Let me, what is, it was, okay. No, Bareilly, you were asking me, no, Bilaspur was asking me to please answer about something. Bilaspur, what do you want me to answer about? Okay, thank you, Bareilly. Good night. बच्चे, गुलबर्गा, मैगसल्फ का एंड पॉइंट विल डिपेंड अपॉन पहले क्या चीज हुआ था. इसका मतलब क्या है? मान लो पेशेंट सुबह 10 बजे डिलीवर हुई, राइट? मगर उसने फिट डिलीवर होने के 2 घंटे बाद 12 बजे भी थ्रो किया, देन द लास्ट डोज ऑफ मैग्नीशियम सल्फेट वुड बी 12 o'clock the next day and not 10 o'clock. So whichever is later. All right, yes. Good night, Haldwani. Good night, Kota. Gulbarga, is it out cleared? Yes, Hubli, now you were asking me something. What were you asking me? No, bache, Bilaspur, proteinuria is not a feature of gestational hypertension. Proteinuria is a feature of preeclampsia. So we don't see proteinuria in gestational hypertension. We see proteinuria in preeclampsia. Hubli was asking me what is reversal. I said what we try and do is we see the blood flow in the umbilical artery of the baby, right, in order to see what is the blood supply? Is it a good blood supply to the baby or a bad blood supply? So initially what will happen? The blood flow is going to be a forward flow, always. Whether you talk about systole or whether you talk about diastole, it is going to be a forward flow. But agar और uteroplacental circulation कम हो गई, next thing will be systole में forward flow होगा, लेकिन diastole का flow बंद हो जाएगा. So that is absent in diastolic flow. Still the next phase is that forward flow in systole and a reversal of flow in the diastole of the fetal cardiac cycle in the umbilical artery. So when that is occurring, it is a terminal event and it needs for urgent or immediate delivery. That is what it means, Hubli. Quota, difference between primordial and primary follicle. Okay, so primordial follicle is only the primary oocyte surrounded by a single layer of granulosa cells. Right, that is primordial. Primary is primary oocyte with more than one layer of granulosa cells. That is what it means. The granulosa cells start, increasing in number and increasing. So they are more than single layer in a primary follicle, whereas there are a single layer in the primordial follicle. Gulbarga, there is no difference between physiological and pathological edema. That is precisely the reason why edema has been removed from the diagnostic criteria of preeclampsia, because we do not know up till what stage it is physiological and at what stage it becomes pathological. That is entirely the reason why it is no longer one of the criteria for diagnosis of preeclampsia. Right, Gulbarga? Do you understand that? Okay, thank you. Anybody else? Hubli, have you understood what you were trying to ask about reversal of blood flow? Or still not clear? Okay. Yes, Miraj. What do you want to know? AMTSL, uterotonic agents. I said the agent of choice is oxytocin. The second line agent is methergin. The third agent is symptometrine. And the fourth is misoprostol. Oxytocin, methergin, symptometrine and misoprostol. Third is symptometrine. I will write it down for you, Miraj. Details, why? Where were you in the class? We did that yesterday in quite details. So for that you'll have to see these slides. I can't repeat the entire topic, beta. So the third is symptometrine. So ask them, they'll put up these slides for you. Right? The cause of blurring of vision. See, there is going to be hypertensive retinopathy. So blurring of vision and scotomas are all because of hypertensive retinopathy, even diplopia. Whereas the terminal event, which is blindness, would be either because of cerebral hypoxia or retinal detachment. So all these visual changes are because of hypertensive retinopathy. Hubli. Yes, anything else, or we can go home now? Hubli, are you is it clear? Symptometrine. Symptometrine is a premixed formulation of oxytocin and methergin. So it has 5 units of oxytocin and 0.5 units of methergin. It is not available in India, or available in very maybe private hospitals or in restricted areas in India. Otherwise it is not easily commercially available. Miraj, symptometrine. Okay, so then we stop the class, right? Anybody else left with their doubts, or can I go home? Alright, so I think we're done with the doubts. So good night, we meet next time, and most likely we'll start with labor in the next class, right?